Hey guys, tonight we begin with ancient women's bodies, where periods meant agony and pregnancy meant possible death. Because, let me tell you, for thousands of years, childbirth killed more women than war, plague, or famine combined. So, before you get comfortable, take a moment to like the video and subscribe, but only if you genuinely enjoy what I do here. And let me know in the comments where you are tuning in from and what time it is for you. It is always fascinating to see who is joining us from around the world. Now, dim the lights, maybe turn on a fan for that soft background hum, and let's ease into tonight's journey together. Think about modern medical care for a moment. When you experience menstrual cramps, you can pop an ibuprofen and get on with your day. During childbirth, there is an epidural waiting with your name on it, trained doctors monitoring every vital sign, and a surgical team ready if things go wrong. The maternal mortality rate in developed countries is about 17 deaths per 100,000 live births. Now imagine a world where that number is 1,000 to 1,500 deaths per 100,000 births, where dying in childbirth is so common that every woman personally knows multiple people it has happened to, where your monthly period arrives with zero pain relief, zero understanding of what is actually happening inside your body, and a society that considers you ritually impure and dangerous for a week. That was reality for billions of women across thousands of years, according to Dr. Rebecca Fleming from Cambridge University, whose research on women's health in ancient civilizations has transformed our understanding. Women's reproductive experiences in the ancient world were marked by pain, danger, and profound vulnerability. Tonight, I'll take you inside the monthly reality of menstruation across different ancient cultures, the rags and wool, the shame and secrecy, the remedies that ranged from helpful to deadly. You'll meet women facing childbirth knowing they might not survive, attended by midwives working with limited knowledge and no modern tools, supported by traditions that sometimes helped and sometimes killed. We'll explore how different civilizations understood, or completely misunderstood, women's bodies, the astronomical maternal mortality rates that shaped entire societies, the infant deaths that were so common they barely warranted recording, and the incredible resilience of women who faced these realities generation after generation. This isn't just a story about suffering. According to Dr. Helen King from the Open University, it is also about the knowledge systems women developed, the support networks they created, the small acts of kindness between women facing shared dangers, and the triumph of continuing humanity, despite odds that would seem impossible today. So settle in, because we're about to spend the night exploring something that connected billions of women across thousands of years. The experience of having a female body in times when that meant confronting monthly pain and potentially deadly childbirth with courage, community, and whatever meager resources were available. Let's start with something that happened to roughly half the population every single month for most of their adult lives: menstruation. According to anthropological research by Dr. Alma Gottlieb from the University of Illinois, virtually every human culture has developed beliefs, practices, and taboos around menstruation, but the actual physical management of monthly bleeding varied enormously across time and place. Meet Nefertari, a woman living in ancient Egypt around 1250 BCE. You are in your mid-20s, married, mother of 2 living children and one who died in infancy. According to demographic research by Dr. Rosalie David, you can expect to menstruate from around age 12 to 14 until your early 40s if you survive that long, with interruptions for pregnancies and breastfeeding. That means roughly 400 menstrual periods over your lifetime, each lasting 4 to 7 Daltons. You'll spend approximately 2,400 days, more than 6 years of your life, actively menstruating. Think about what this means without modern products. According to archaeological evidence analysed by Dr. Joan Fletcher, ancient Egyptian women used folded linen cloths as menstrual absorbents. Linen made from flax was Egypt's primary textile. You would fold rectangular pieces of linen into pads, position them between your legs, and secure them somehow, possibly with a belt arrangement, though the exact mechanics aren't well documented, because ancient sources rarely discussed such women's matters in detail. The linen had to be washed after use. According to Egyptian household practices reconstructed by Dr. Lynn Meskel, washing menstrual cloths was done privately, often at night or early morning at the river's edge, because menstrual blood carried powerful taboos. Egyptian medical texts, analysed by Dr. John Nunn, describe menstrual blood as having both dangerous and beneficial magical properties. It was simultaneously polluting and potentially powerful in certain rituals and medical preparations. But here is what archaeological evidence and medical papyri reveal. Egyptian women suffered significant menstrual problems without effective treatment. According to the Kahun Gynecological Papyrus, dating to around 1800 BCE and analysed by Dr. Stephen Quirk, physicians diagnosed numerous womb disorders, causing pain, excessive bleeding, or absent periods. The treatments, fumigations with various substances, drinking concoctions containing ingredients from donkey liver to fly excrement, ranged from harmless placebos to potentially dangerous. You experience severe cramping every month. According to modern medical understanding, menstrual cramps result from prostaglandin production, causing uterine contractions. Ancient Egyptians had no concept of prostaglandins or what caused menstrual pain. According to medical papyri, they attributed painful periods to the womb wandering within the body, to evil spirits, to divine punishment, or to imbalances of bodily fluids. The remedies reflected these misunderstandings, fumigating the vagina with incense to lure the wandering womb back to its proper position, drinking beer mixed with dates and honey, applying heated oils to the abdomen. Some of these treatments provided minimal relief. According to Dr. Nunn's analysis, the heated oils on the abdomen worked similarly to a modern heating pad, the warmth temporarily easing muscle contractions. Beer contained small amounts of pain, relieving compounds from the fermentation process, but the relief was slight and temporary. For the most severe cramps, you simply endured, lying down when possible, continuing with reduced capacity when necessary, suffering through pain that modern medicine could reduce with a single pill. Now let's shift to ancient Greece, because Greek medical understanding of menstruation reveals fascinating and deeply flawed theories that influenced Western medicine for thousands of years. According to Dr. Helen King's comprehensive research on Greek gynecology, Greek physicians developed elaborate theories about women's bodies that were almost entirely wrong but tremendously influential. Meet Althea, a woman living in Athens around 350 BCE. According to Greek medical theory, as explained in the Hippocratic texts analysed by Dr. King, your body is fundamentally different from men's bodies in dangerous ways. Greek physicians believed women were colder and wetter than men, that your flesh was more porous and sponge-like, and that you needed to menstruate to expel excess harmful fluids that would otherwise poison your system. Think about the implications of this medical framework, according to Hippocratic theory. If you didn't menstruate regularly, the retained blood could cause all sorts of terrible conditions: suffocation, madness, wandering womb, even death. Greek physicians were obsessed with ensuring menstruation occurred. According to Dr. King's research, they prescribed aggressive treatments to bring down the menses, inserting irritating pessaries into the vagina, giving women substances to drink that induced vomiting or diarrhea, applying leeches to the legs, even bloodletting from the arms to substitute for menstrual flow. For actual menstrual management, according to archaeological and literary evidence, you used wool. Greece's primary textile was wool from sheep, and according to references in medical texts, women used wool as menstrual absorbent material. The wool was formed into tampons, or pads, inserted or positioned, then removed, and either washed for reuse or discarded. But wool presented problems. According to modern textile analysis, wool is less absorbent than linen and can irritate sensitive tissue. Greek medical texts, analysed by Dr. Leslie Dean Jones from the University of Texas, frequently mention vaginal irritation, infections, and inflammation. Some of this resulted from the aggressive medical treatments, but some probably came from using wool as menstrual material, especially if it wasn't cleaned properly between uses. Your menstrual experience is also shaped by Greek cultural attitudes. According to Dr. Froma Zeitlin's research on gender in Greek society, menstruating women were considered ritually impure and potentially dangerous. You couldn't participate in religious ceremonies, enter temples, or touch sacred objects. Some sources suggest you were expected to avoid sexual activity, though marital realities meant this wasn't always observed. The cultural message was clear: your menstruating body was problematic, dangerous, and shameful. According to research by Dr. Anne Hansen on ancient gynecology, Greek women developed their own knowledge networks separate from male physicians. Women shared information about managing periods, treating cramps, dealing with heavy flow. These women's networks preserved practical knowledge that male medical texts ignored: which herbs actually helped with pain, how to fashion more comfortable absorbent materials, which physicians were less invasive in their treatments. Now let me introduce you to a Roman woman's experience, because Rome inherited Greek medical theories while adding its own cultural practices. Meet Claudia, a woman living in Rome around 150 CE. According to Dr. Rebecca Fleming's research on Roman women's medicine, you navigate a complex landscape of male medical theory, female practical knowledge, and cultural taboos. Roman medical writers, particularly Serranus of Ephesus, whose gynecological texts are analysed by Dr. Ose Temkin, continued Greek theories about women's bodies, while adding some observations based on actual anatomical knowledge. Serranus correctly understood more about female anatomy than Hippocratic writers, but he still fundamentally misunderstood menstruation, believing it served to expel harmful residues rather than being part of the reproductive cycle. For menstrual materials, according to archaeological evidence from Roman sites, you use linen or wool cloths formed into pads. Some wealthy Roman women might have had access to sea sponges, which, according to references in medical texts, were sometimes used as tampons. The logistics of managing menstruation in a Roman city added complications. You needed clean water for washing cloths, privacy for changing materials, and disposal methods for soiled items. Think about the practical challenges. According to research on Roman urban life by Dr. Ray Lawrence, you live in a multi-story apartment building, an insula, sharing facilities with numerous other families. Privacy is minimal. Water must be carried from public fountains. Washing menstrual cloths discreetly is difficult. You probably do it at night or very early morning, hoping neighbours don't notice and gossip about it. Roman culture added its own layer of menstrual taboos. According to Pliny the Elder's Natural History, analysed by numerous scholars, Romans believed menstruating women could cause crops to fail, wine to sour, iron to rust, bees to abandon hives, and mirrors to tarnish. According to Pliny, even menstrual blood itself had powerful and dangerous properties. It could cure some ailments, but cause others, could drive away pests, but also poison food. These beliefs affected your daily life during menstruation. According to social expectations reconstructed by Dr. Fleming, you might be expected to avoid certain activities, stay away from food preparation for others, and generally keep your menstruating state as invisible as possible. The shame and secrecy surrounding menstruation meant you couldn't discuss your pain openly, couldn't ask for accommodation when you were suffering, and certainly couldn't expect much sympathy from male family members who found the whole topic disgusting and frightening. For menstrual pain, according to Roman medical texts, you might try various remedies. Warm baths were recommended, Rome's famous bathing culture meant you had access to heated water, which, according to Dr. Fikret Yegel's research on Roman baths, did provide genuine relief through heat therapy. Wine mixed with herbs was prescribed for various conditions, including menstrual complaints. Some herbs actually contained mild analgesic properties, though the effect was far weaker than modern pain relievers. But, according to the reality documented in medical texts and epitaphs, many Roman women suffered severely with menstrual problems. Endometriosis, fibroids, ovarian cysts, hormonal disorders, all the conditions that cause severe menstrual pain today existed then, but without diagnosis, without effective treatment, without even proper understanding of what was happening. You either endured or died, with little middle ground. Now, let's shift to childbirth, because this is where ancient women's experiences become truly harrowing. According to demographic research by Dr. Walter Scheidel from Stanford University, maternal mortality in the ancient world was approximately 1,000 to 1,500 deaths per 100,000 live births, roughly 50 to 100 times higher than modern developed countries. Over a lifetime of multiple pregnancies, a woman's cumulative risk of dying in childbirth was somewhere between 5 to 10%. Think about that. 1 in 10 to 1 in 20 women died from pregnancy or childbirth complications. Meet Tertia, a woman in ancient Rome about to give birth to your third child around 140 CE. According to your experience and that of women around you, childbirth is the most dangerous thing you'll ever do. According to Dr. Keith Hopkins's demographic research, you've already beaten significant odds. Many women died during their first or second deliveries. You've lost friends to childbirth. You've seen women die from hemorrhage, from infection, from obstructed labor, from seizures. You know, with absolute certainty, that you might not survive the next few days. Think about your preparation. According to Roman birthing practices, analyzed by Dr. Vedronik Dassen, you've consulted with the midwife who will attend you. In Rome, according to medical texts, midwifery was a recognized profession, and some midwives, like Salp, whose remedies are mentioned in medical texts, were renowned for their skill. But even the best midwife in ancient Rome was working with extremely limited tools and knowledge. Your birthing room is prepared according to traditional practices. According to Dr. Dassen's research on Roman birthing imagery, you'll give birth sitting on a birthing stool, a chair with a curved seat, and an opening in the center. The midwife will sit or crouch in front of you, ready to catch the baby. Female relatives and friends will attend, supporting you physically and emotionally. No men are present except possibly a physician if complications arise, and according to Dr. Fleming's research, male physicians attending births was actually relatively rare and often a sign that something was going terribly wrong. Labor begins. According to the Hippocratic texts and Soranus's gynecological treatise, analyzed by scholars, ancient medical understanding of labor was limited and partly incorrect. They understood that the uterus contracted to expel the baby, but they believed the baby actively participated in birth, using its own strength to emerge. They had no concept of the complex hormonal cascade that initiates and sustains labor. Think about the pain. According to modern obstetric understanding, labor contractions rank among the most intense pain experiences humans can have, comparable to severe burns or kidney stones. The pain comes in waves, building to peaks that can last 60 to 90 zecons, occurring every few minutes, sometimes for many hours. You are experiencing this pain without epidurals, without spinal blocks, without intravenous pain medication, without any of the interventions that modern medicine offers. What you have, according to ancient medical texts, are herbs and prayers. The midwife gives you wine mixed with herbal preparations. Some herbs mentioned in ancient sources, like willow bark, which contains salicylic acid similar to aspirin, provided minimal pain relief. Others, like opium poppy in regions where it was available, offered stronger relief but came with risks of respiratory depression. especially dangerous during labor when you need to push effectively. According to Dr. Dasson's research on birthing practices, the women attending you provide crucial support. They hold you upright on the birthing stool. They rub your back and abdomen. They encourage you. They pray to goddesses of childbirth like Juno, Lucina, or Artemis. This emotional and physical support, according to modern research on labour support by Dr. Megan Bowen from the University of Melbourne, actually does help. Continuous labour support can shorten labour, reduce complications, and improve outcomes even without medical interventions. But sometimes support isn't enough. According to your worst fears, labour might not progress normally. The baby might be positioned wrong. The placenta might block the cervix. The baby might be too large. You might start hemorrhaging. Any of these complications, according to ancient medical capabilities, could be fatal. Let's talk about what happens when childbirth goes wrong. Meet Valeria, a woman in ancient Rome whose labour has stalled after 24 hours around 180 CE. According to Serranus's detailed descriptions of abnormal presentations, analysed by Dr. Temkin, the midwife has attempted to reposition the baby manually, reaching into your uterus to turn the child. This procedure, according to modern obstetric knowledge, is excruciatingly painful, risks tearing delicate tissues, and can cause hemorrhage or infection. Think about the midwife's perspective. According to the training described in ancient medical texts, she has learned techniques passed down through generations of midwives. She knows how to manually rotate a baby from breech to head-down position, how to deliver a baby presenting arm first by pushing the arm back and finding the head, how to extract a baby who is stuck. But according to Dr. Dasson's analysis, these techniques were dangerous, painful, and often unsuccessful. If the midwife can't resolve the obstruction according to Roman medical practice, a physician might be called. Physicians, according to Serranus's descriptions, had access to hooks and knives for embryotomy, the process of dismembering a stuck baby to extract it piece by piece and save the mother's life. According to Dr. Fleming's analysis, this horrific procedure was sometimes the only option when a baby became lodged in the birth canal. Think about experiencing embryotomy. According to the procedure described in medical texts, you are exhausted from days of failed labour, weakened from pain and blood loss, possibly feverish from developing infection. The physician inserts hooks or sharp instruments into your uterus, pierces the baby's body, and gradually pulls it out in pieces. You are conscious throughout this, feeling each cut, each pull, each extraction. The pain, according to modern pain research, would be absolutely unbearable. Some women, according to medical accounts, died from shock during the procedure. Others survived the embryotomy, but died later from hemorrhage or infection. But even if the procedure succeeded and you survived, according to the psychological impact analysed by Dr. Sarah Pomeroy in her research on ancient women, you'd carry the trauma forever. You'd lost your baby in the most terrible way possible. You'd been subjected to mutilating surgery without anaesthesia, and you'd likely face social stigma, according to Roman beliefs. A woman whose baby died in childbirth might be seen as cursed or impure. Now let's examine hemorrhage, because this was one of the leading causes of maternal death. According to modern obstetric data, postpartum hemorrhage occurs in about 5 to 10% of deliveries. In the ancient world, according to medical texts, severe bleeding after birth was recognized as extremely dangerous and often fatal. Meet Faustina, a woman who has just delivered a healthy baby but is now hemorrhaging uncontrollably around 200 CE. According to Serranus's descriptions of this complication, the midwife tries various interventions. She presses on your abdomen to encourage the uterus to contract and stop bleeding. She gives you substances believed to stop hemorrhage, astringent herbs, cold water to drink, vinegar compresses. She manually removes any placental fragments left in the uterus, though this risks causing more bleeding or introducing infection. Think about what you are experiencing. According to modern medical understanding, you are losing blood faster than your body can compensate. You feel weak, dizzy, cold. Your vision narrows, your heart races trying to maintain blood pressure. According to ancient descriptions in medical texts, you become pale as death. Cold sweat covers your body. You might lose consciousness. The women attending you watch helplessly as you bleed, knowing they're probably about to witness your death. Without blood transfusions, without medications to promote uterine contraction, without surgical intervention to find and stop the bleeding source. According to Dr. Fleming's research, there was essentially nothing ancient medicine could do about severe postpartum hemorrhage. Either the bleeding stopped on its own or you died, usually within hours. Your newborn baby would become motherless. Your older children would lose their mother. Your husband would become a widower. All because of a complication that modern medicine treats routinely. Let's talk about puerperal fever, childbed fever, because this infection killed enormous numbers of women in the days and weeks after delivery. According to research by medical historian Irvine Loudon, puerperal fever is caused by bacterial infection of the reproductive tract, usually introduced during delivery by unwashed hands or contaminated instruments. Before germ theory and antibiotics, according to Dr. Loudon's analysis, it was a major killer of new mothers. Meet Livia, a Roman woman who delivered successfully 5 days ago, but is now developing symptoms of puerperal fever around 190 CE. According to ancient medical descriptions analysed by Dr. Anne Hansen, you are experiencing fever, severe abdominal pain, foul-smelling discharge. Ancient physicians and midwives recognised this syndrome. They called it variations of burning fever after birth, but they had no understanding of its bacterial cause. The treatments, according to medical texts, were useless or harmful. Bloodletting to reduce fever actually weakened you further. Fumigations with various substances did nothing for bacterial infection. Poultices and applications of different materials might feel soothing but didn't address the infection spreading through your reproductive system. According to modern medical understanding, untreated puerperal fever has a mortality rate of 20 to 30%. You either survived because your immune system cleared the infection, or you died, usually after days of agonizing fever and pain. Think about the tragedy of puerperal fever. According to Dr. Loudon's research, this complication was largely iatrogenic, caused by medical intervention. The midwife or physician trying to help you introduced bacteria with unwashed hands. The manual manipulations, the instrumental interventions, the examinations by multiple attendants, all of these increased infection risk. You survived the dangerous work of labour and delivery, only to die from an infection introduced by those trying to help you. Now, let's explore childbirth in other ancient cultures, because the experience varied across civilizations, while remaining universally dangerous. According to Dr. Salima Ikram's research on ancient Egypt, Egyptian women gave birth attended by midwives and female relatives, invoking goddesses like Tarot, the hippopotamus goddess of childbirth, and Bees, a protective deity. Meet Mutamwea, an Egyptian woman in labour around 1400 BCE. According to artistic depictions and medical papyri analysed by Dr. Joyce Tildersley, you are probably giving birth while squatting or kneeling on birthing bricks, special bricks inscribed with magical symbols and images of protective deity. The midwife attends you, using techniques passed down through generations. Female musicians play to encourage you and to please the goddesses. Incense burns to create a sacred atmosphere and presumably to mask other smells. Egyptian medical papyri, according to Dr. John Nunn's analysis, contain numerous spells and remedies for pregnancy and childbirth. Some are practical herbs that might genuinely help with pain or bleeding. Others are purely magical spells to recite, amulets to wear, rituals to perform. The mixture of practical knowledge and magical thinking was typical of ancient medicine, but it meant that even the best care was limited by fundamental misunderstandings of physiology. According to papyrus texts on obstetric complications, Egyptians recognized that childbirth could go wrong in various ways. They described obstructed labor, breech presentations, hemorrhage. Their treatments included manual manipulation, herbal remedies, and ultimately acceptance that some women and babies would die despite all efforts. According to Dr. Tildesley's demographic research, maternal mortality in ancient Egypt was probably similar to other ancient cultures, horrifically high by modern standards. Let's examine ancient Mesopotamia, because cuneiform medical texts reveal another civilization's attempts to manage childbirth dangers. According to research by Dr. Joanne Scurlock on Mesopotamian medicine, Babylonian and Assyrian women gave birth attended by midwives, with knowledge recorded in medical compendia. Meet Anatum, a woman in ancient Babylon giving birth around 1750 BCE. According to cuneiform texts analysed by Dr. Scurlock, the midwife attending you knows various techniques for difficult deliveries. She uses olive oil to lubricate the birth canal. She recites incantations invoking protective deities. She prepares medicinal drinks containing herbs believed to ease labour. She knows how to manually reposition a baby that is presenting abnormally. But according to Mesopotamian medical understanding, as reflected in cuneiform texts, illness and complications were often attributed to demons or divine punishment. A difficult labour might mean you'd offended a deity or been cursed by an enemy. Alongside practical midwifery, according to Dr. Scurlock's research, you'd receive magical interventions, amulets, spells, rituals to appease gods and drive away demons. The supernatural framework meant that when interventions failed, the explanation was spiritual rather than medical, which prevented development of better practical treatments. Mesopotamian texts, according to Dr. Scurlock's translations, also reveal a hierarchy of concerns during childbirth. The baby's survival was paramount, then the mother's life, then the mother's future fertility. According to this value system, a midwife facing a choice between definitely saving the mother or trying to save both mother and baby would often attempt the latter, even if it increased maternal risk. Women's lives, according to the social values reflected in these texts, were important primarily for their reproductive capacity. Now let's shift to medieval Europe, because the continuation of ancient medical knowledge into the Middle Ages meant women's experiences remained similarly dangerous for centuries. According to Dr. Monica Green's research on medieval women's healthcare, medieval European medicine inherited Greek and Roman theories about women's bodies, filtered through Islamic medical scholarship and Christian religious frameworks. Meet Agnes, an English peasant woman giving birth around 1250 CE. According to demographic research by Dr. Barbara Hannawalt, you are giving birth in a one-room cottage, attended by a local woman with midwifery experience, but no formal training. Your female neighbours attend, offering support and prayers. The local priest might be called to perform emergency baptism if the baby seems unlikely to survive, because according to Christian belief, unbaptized babies couldn't enter heaven. Medieval European childbirth, according to Dr. Green's research, combined ancient medical knowledge, Christian religious practice, and folk traditions. The midwife attending you might have read or heard about techniques described in medical texts, but more likely she has learned through apprenticeship and experience. She knows practical measures, positioning, massage, herbal drinks. She also relies heavily on prayer, invoking the Virgin Mary and various saints associated with childbirth protection. Think about the additional burden medieval Christian beliefs placed on childbirth. According to religious teachings analysed by Dr. Clarissa Atkinson, childbirth pain was Eve's curse, punishment for original sin. This theological framework meant your suffering was not only natural but deserved. Requesting pain relief might be seen as trying to escape divinely mandated punishment. According to this logic, you should suffer through labour as penance, offering your pain to God. Medieval medical texts, according to Dr. Green's analysis, reveal continued misunderstanding of female anatomy and physiology. The womb was still described as capable of wandering through the body. Menstrual blood was considered toxic waste that needed regular expulsion. Pregnancy was understood in terms of humoral theory, balances of hot, cold, wet and dry qualities. These frameworks inherited from ancient medicine and passed through Islamic scholars like Avicenna, persisted in Europe for centuries. For childbirth complications, according to medieval medical texts, analysed by Dr. Green, European practitioners had limited interventions. They could attempt manual repositioning of malpositioned babies. They could give herbal remedies, some helpful, many useless. In extreme cases, they could perform embryotomy to save the mother's life. But according to religious restrictions, caesarean section on a living woman was forbidden. It was only performed post-mortem to attempt to save the baby and allow for baptism before death. Think about dying in medieval childbirth. According to burial practices analysed by Dr. Roberta Gilchrist, women who died in childbirth were sometimes buried with their unbaptized infants, creating joint graves that archaeologists still discover. These graves are stark reminders of the double tragedies that were heartbreakingly common, mother and baby both dying in the process of trying to bring new life into the world. Let's explore the emotional and psychological toll of these experiences. According to research by Dr. Sarah Ritchie on medieval women's spiritual lives, constant proximity to death during childbirth shaped women's religious practices, social relationships, and psychological coping mechanisms. Meet Matilda, a medieval woman who has survived 3 childbirths but lost 2 babies in infancy around 1320 CE. According to your lived experience, pregnancy means 9 months of anxiety, wondering if you'll survive, wondering if the baby will survive, making preparations that include planning for your own possible death. You've made a will. You've confessed your sins. You've prepared gifts for the church in hopes that prayers will be said for your soul if you die. During labour, according to practices documented by Dr. Ritchie, you wear special amulets or relics. You've borrowed a birth girdle, a cloth belt supposedly touched to holy relics. That is believed to provide protection during delivery. Women in your community pass these items among themselves, creating networks of shared religious objects and shared experiences. The communal support, according to modern psychological research on social support during stress, probably did help you cope with fear and pain, even if the religious objects themselves had no medical efficacy. After surviving childbirth, according to Dr. Ritchie's research, you participate in churching, a religious ceremony where you are ritually purified and welcomed back into church community after the polluting experience of childbirth. This ceremony, according to religious historians, reflects medieval Christian ambivalence about childbirth. It was necessary for continuing humanity and was blessed by God, yet it was also associated with Sin Eve's curse, pollution, blood and bodily fluids, and female sexuality. The constant threat of maternal death, according to Dr. Hannawalt's research on medieval families, shaped all of social life. Women wrote wills before each pregnancy. Families prepared for the possibility of motherless children and widowed fathers. Communities developed systems for caring for orphans and supporting widowers. The ever-present danger of losing mothers to childbirth was a fundamental feature of medieval social structure. Now, let's examine some of the specific medical interventions that were attempted for difficult labours, because understanding what ancient and medieval practitioners tried reveals both their genuine desire to help and their dangerous ignorance. According to Dr. Helen King's analysis of gynecological texts, ancient physicians developed numerous interventions for childbirth complications, ranging from sensible to horrifying. One common intervention across cultures was manual manipulation of malpositioned babies. According to Soranus's detailed instructions, a midwife or physician might reach into the uterus to reposition a baby presenting feet first, arm first, or at an awkward angle, Modern obstetricians, according to Dr. Frank Chervenak from Cornell Medical College, recognize that some of these maneuvers were actually correct, turning a baby from breech to vertex presentation through external cephalic version or, when necessary, internal manipulation. But think about experiencing these procedures without anesthesia. According to modern pain research, manual uterine manipulation ranks among the most painful procedures possible. The midwife's hand entering your uterus, feeling for the baby's position, grasping limbs or head, attempting rotation or repositioning. Every movement causes excruciating pain. According to ancient medical texts, women sometimes died from shock during these procedures. Others developed infections from the intervention. Even successful repositioning came at a terrible cost in suffering. Another intervention was the use of various substances to speed labor. According to medical texts from multiple cultures analyzed by Dr. John Riddle, numerous plants were believed to promote labor contractions, including ergot, a fungus growing on grains, certain roots and barks, and preparations from animal sources. Some of these, according to modern pharmacological analysis, actually do contain compounds that stimulate uterine contractions. Ergot, for instance, contains ergometrine, which is still used medically to prevent postpartum hemorrhage, but using these substances was extremely dangerous. According to modern obstetric knowledge, artificially stimulating strong contractions in an obstructed labor can cause uterine rupture, a catastrophic complication that is almost always fatal without immediate surgical intervention. Ancient practitioners, not understanding the physiology, might give labor, promoting herbs to a woman whose baby couldn't physically pass through the pelvis, causing the uterus to tear itself apart, trying to expel an impossibly positioned baby. Let's talk about superstitious and magical interventions, because these reveal the desperate desire to control uncontrollable situations. According to Dr. Veronique Dasson's research on birth imagery and practices, ancient cultures developed elaborate rituals and used numerous magical objects to protect women during childbirth. Roman women, according to archaeological evidence, wore amulets containing inscribed spells or images of protective deities. Egyptian women, as we discussed, gave birth on special bricks inscribed with protective symbols. Medieval European women wore relics or birth girdles. According to anthropological research on magical thinking by Dr. Bronislaw Malinowski, these practices served psychological functions even when they had no medical efficacy. They gave women a sense of control, provided comfort, and created shared rituals that strengthened community bonds. But some magical interventions were actively harmful. According to medieval medical texts analysed by Dr. Monica Green, some traditions called for giving labouring women unusual substances, powdered gemstones, burnt animal parts, extracts of dangerous plants, based on magical rather than medical reasoning. Women already weakened by labour might be given emetics to induce vomiting, believed to sympathetically promote downward movement of the baby, or subjected to sudden loud noises, believed to startle the baby into movement. Meet Christina, a medieval woman whose labour has been slow, now being subjected to a traditional intervention around 1280 CE. According to folk traditions documented in later sources by historians, the midwife has your husband remove his belt and place it around your waist, has opened all locks and knots in the house, and has given you a drink containing pulverized eagle stone, a geological formation believed to have special properties. None of this, according to modern obstetric knowledge, has any effect on labour progress, but you and everyone attending you believe these interventions might help, and that belief shapes your experience, even if it doesn't change the medical outcome. Now, let's explore the experiences of women who survived childbirth only to face inadequate postpartum care. According to Dr. Rosalie David's research on health in ancient Egypt, the postpartum period, the weeks after delivery when the uterus returns to normal size and the body heals, was another dangerous time for ancient women. Meet Tabitha, a woman who delivered successfully 3 days ago, but is now facing postpartum complications around 250 CE in Roman Syria. According to Cyranus's recommendations for postpartum care, you should rest in a warm, dark room for several days, drink wine mixed with healing herbs and gradually resume activity. But according to your economic reality as a working woman, you can't afford extended rest. Your family needs you working, caring for older children, managing the household. Think about your physical condition. According to modern medical understanding, your uterus is still contracting and shrinking, causing painful cramping. You are experiencing lochia, postpartum vaginal discharge that can last for weeks. If you tore during delivery or the midwife cut you to enlarge the opening, a procedure mentioned in ancient texts, you have painful wounds in the most sensitive areas, and every movement, every time you need to urinate or defecate, causes sharp pain. You are also trying to breastfeed your newborn. According to research by Dr. Valerie Fields on the history of breastfeeding, women in most ancient and medieval cultures nursed their own children, unless they were wealthy enough to hire wet nurses. Breastfeeding, according to modern knowledge, can be challenging. Nipples crack and bleed. Milk supply is initially uncertain. The baby's constant need to nurse is exhausting. In the ancient world, according to medical texts, numerous problems could arise: breast infections, abscesses, blocked milk ducts, and the treatments were limited. For breast problems, according to Roman medical texts analysed by Dr. Fleming, midwives recommended various applications: warm compresses, oils, poultices made from bread and milk. For severe infections, physicians might lance abscesses, a painful procedure that risked spreading infection. Women who couldn't breastfeed faced a serious problem according to demographic research. Babies who weren't breastfed had much higher mortality rates, both because alternative foods, animal milk, grain porridges were nutritionally inadequate, and because they lacked the immune protection provided by breast milk. Let's talk about infant mortality, because the maternal experience of pregnancy and childbirth was inextricably linked to the heartbreaking frequency of infant death. According to Dr. Walter Scheidel's demographic research, infant mortality in the ancient world was approximately 25 to 30% in the first year of life. Nearly 1 in 3 babies born alive died before their first birthday. By age 10, according to demographic models, roughly 50% of children had died. Meet Lucia, a Roman woman who has just lost her 6-month-old baby to fever and diarrhea, your 3rd child to die in infancy, around 170 CE. According to your devastating experience, you've now had 5 pregnancies. 1 ended in miscarriage. 4 resulted in live births. 3 of those babies died, 1 at 2 weeks, 1 at 4 months, 1 at 6 months. You have 1 surviving child, a daughter now 3 years old. The grief, according to funerary inscriptions analysed by Dr. Maureen Carroll, was real and deep despite the frequency of child death. Think about the emotional calculus this forced on mothers. According to research on parental investment by anthropologist Sarah Hardy, some ancient cultures developed practices that might seem heartless, but represented adaptation to high infant mortality: delayed naming ceremonies, limited emotional investment in very young infants, acceptance that not all children could be saved. These weren't signs of not loving children, but rather psychological defences against unbearable, repeated grief. But according to funerary evidence, ancient parents grieved deeply for lost children. Tombstones mourned sweet little ones taken too soon. Parents commissioned touching memorials showing deceased children playing with pets or toys. According to literary sources, parents experienced profound sorrow even in cultures where child death was common. The frequency of loss didn't make each death hurt less. It just meant the pain was an expected part of parenthood. Now let's examine the experiences of women from different social classes, because wealth made some difference in childbirth outcomes, though not as much as you might expect. According to Dr. April Pudsey's research on social status and health in ancient Rome, elite women had access to better nutrition, more skilled midwives, and less physically demanding lives, all of which improved their chances. But according to demographic analysis, they still faced substantial maternal mortality risk. Meet Julia, a wealthy senator's wife in Rome preparing for childbirth around 200 CE. According to your social position, you can afford the best midwife in the city. A woman trained by physicians and experienced with hundreds of deliveries. You've consulted with physicians during pregnancy. You are well nourished, having eaten meat, fish, fruits, and vegetables throughout pregnancy, while poor women subsisted on grain and little else. You'll give birth in a well-appointed room with clean linens, attended by multiple slaves to assist the midwife. But according to the medical realities, your wealth can't protect you from many childbirth dangers. If your baby is positioned wrong, the best midwife in Rome can only attempt the same dangerous manual manipulations that any midwife would try. If you hemorrhage severely, there is no blood transfusion available regardless of your wealth. If you develop an infection, there are no antibiotics, no matter how much gold your husband offers. According to epitaphs of wealthy Roman women analysed by Dr. Carroll, even senators' wives, even members of the imperial family, died in childbirth with heartbreaking regularity. Your wealth does provide some advantages. According to Dr. Fleming's research, you are less likely to be malnourished, anemic, or suffering from parasitic infections, all conditions that complicate pregnancy and delivery. You can afford proper postpartum rest, hiring wet nurses and slaves to handle household work while you recover. You are more likely to survive the immediate postpartum period because you are not forced back to physical labor while still healing. But the fundamental dangers of childbirth in ancient medicine affected all social classes. According to demographic models, elite women might have had maternal mortality rates around 800 to 1,000 per 100,000 live births compared to 1,200 to 1,500 for poor women. Somewhat better, but still horrifyingly high. Over a lifetime of multiple pregnancies, even wealthy women faced substantial cumulative risk of dying in childbirth. Now let's talk about the knowledge transmission among women, because despite male medical texts and male physicians, most actual women's healthcare knowledge was preserved and transmitted through female networks. According to Dr. Monica Green's research on women's medical knowledge, women developed sophisticated understanding of reproductive health, passed from mother to daughter, between friends, and among midwives. Meet Fabia, a Roman woman training as a midwife around 180 CE. According to Soranus's description of ideal midwife training, you are learning through apprenticeship with an experienced midwife, observing numerous deliveries, practicing techniques under supervision, and studying medical texts if you are literate. But according to Dr. Fleming's research, most midwives learned primarily through observation and practice, developing practical knowledge that wasn't always reflected in male-authored medical texts. Think about what you are learning. You are developing the ability to assess labor progress by internal examination, feeling the cervix to judge dilation, feeling the baby's position, recognizing when progress has stalled. You are learning to judge when a delivery is proceeding normally and when intervention is needed. You are mastering techniques for managing common complications, slowing hemorrhage, delivering the placenta, handling shoulder dystocia. You are learning which herbs genuinely help and which are useless. You are building a mental catalogue of cases. What worked, what failed, what signs preceded bad outcomes. This knowledge, according to Dr. Green's analysis, was valuable and sophisticated within the limitations of ancient medical understanding. Skilled midwives developed genuine expertise through experience with hundreds of deliveries. They recognized patterns, learned from mistakes, shared knowledge with other midwives. The female knowledge networks, according to Dr. King's research, sometimes preserved accurate observations that male medical texts missed. because male physicians had less direct experience with women's bodies. But according to the social structures of ancient societies, women's medical knowledge was devalued compared to male physicians' theoretical knowledge. Midwives, according to legal and social status, were working women, sometimes slaves or freedwomen, whose experiential knowledge was considered inferior to physicians' book learning even when the midwife's practical skills were superior. This gender hierarchy, according to Dr. Green, meant valuable women's knowledge was often lost or dismissed. Let's examine how different women coped psychologically with the constant threat of childbirth death. According to research by Dr. Clarissa Atkinson on motherhood in medieval Christianity, religious faith provided crucial psychological support for women facing maternity's dangers. Meet Eleanor, a medieval English woman preparing for your fourth childbirth around 1340 CE. According to your religious practice, you've been praying to St. Margaret of Antioch, patron saint of childbirth, for protection. You've made offerings at her shrine. You wear a relic that supposedly contains a thread from her garment. You've confessed your sins and received communion, spiritually preparing for the possibility of death. Think about how religious faith shapes your experience. According to medieval Christian belief, if you die in childbirth in a state of grace, you'll go to heaven. The pain you are about to suffer can be offered up as penance for sins, potentially reducing your time in purgatory. According to some theological interpretations analysed by Dr. Atkinson, women who died in childbirth might even be considered martyrs of sorts, dying in fulfillment of God's command to be fruitful and multiply. This religious framework, according to psychological analysis, provided genuine comfort. It gave meaning to suffering, promised eternal reward, and offered hope that death wouldn't be the end. But, according to feminist historians like Dr. Atkinson, it also reinforced women's subordinate status, presenting childbirth suffering as divinely mandated punishment for Eve's sin, discouraging requests for pain relief, and teaching women to accept danger and death as their God-given lot. Now let's talk about the husband's perspective, because men experienced pregnancy and childbirth dangers indirectly but significantly. According to research by Dr. Suzanne Dixon on Roman families, husbands faced the real possibility of losing wives they might love, becoming widowers with young children to care for, and having to navigate remarriage while grieving. Meet Marcus, a Roman man whose wife is in labour with complications around 190 CE. According to social customs, you are not in the birthing room. That is female space, forbidden to men except physicians in extreme cases. You are waiting outside, hearing screams of pain, listening to urgent voices, knowing your wife might be dying, but unable to help or even witness what is happening. According to epitaphs analysed by Dr. Carroll, some Roman husbands expressed genuine grief at wives lost to childbirth, mourning both the spouse and the life they'd planned together. But according to Roman social structures, you also faced practical concerns. If your wife dies, according to legal and social realities, you'll need to arrange her funeral, care for any surviving children, and eventually remarry if you want domestic management and more children. The emotional and practical were intertwined in ways that modern people might find cold, but that reflected ancient realities. Love and loss coexisted with the practical necessities of maintaining households and continuing families. According to medical historian Irvine Loudon's analysis, the exclusion of men from the birthing room persisted in Western culture until the modern era. This separation meant husbands were shielded from witnessing their wives' suffering, but also powerless to help or advocate for them. Women faced childbirth surrounded by other women, in a female space where their screams and blood were hidden from male eyes. This gender separation, according to Dr. Dasson's research, had complex effects. It preserved women's agency and privacy during a vulnerable time, but it also meant the male power structures of society remained largely ignorant of childbirth's realities. Let me introduce you to the Islamic medical tradition's contributions to obstetric knowledge, because Islamic physicians during the medieval period both preserved ancient knowledge and added new observations. According to Dr. Emily Savage, Smith's research on Islamic medicine, physicians like Thabit ibn Qurra and al-Razi wrote texts on women's health that incorporated Greek and Roman knowledge while adding insights from Islamic cultural contexts. Meet Zainab, a woman in 10th century Baghdad, being attended by a midwife trained in techniques described in Islamic medical texts. According to these texts analysed by Dr. Savage, Smith, Islamic physicians understood pregnancy and childbirth in terms of humoral theory inherited from Galen, but modified through centuries of practice and observation. The midwife attending you knows techniques described in Arabic medical compendia, uses herbal remedies from both Greco-Roman and Persian Indian traditions, and operates within Islamic religious frameworks about ritual purity and women's modesty. Islamic medical texts, according to Dr. Savage, Smith's research includes detailed gynecological and obstetric information. They describe fetal development, signs of approaching labour, management of normal delivery, and interventions for complications. Some recommendations align with modern obstetric practice, keeping the labouring woman mobile, allowing her to assume positions she finds comfortable, avoiding unnecessary intervention in normal labour. Others reflect ancient misconceptions that Islamic physicians inherited and transmitted. According to Islamic religious law and cultural practices, female midwives attended births, maintaining gender segregation. Male physicians could be consulted for serious complications, but according to modesty requirements, they might examine women only through drapes or based on verbal descriptions. This created challenges for diagnosis and treatment, but also preserved women's dignity and privacy in ways they valued. Now let's explore some experiences that ancient medical texts barely mentioned, but that devastated countless women: miscarriage and stillbirth. According to modern obstetric data, approximately 10 to 20% of known pregnancies end in miscarriage, with the rate probably higher in the ancient world due to poor nutrition, infections, and physically demanding work. According to demographic research by Dr. April Pudsey, stillbirth rates in the ancient world were approximately 5 to 10% of all pregnancies that reached late term. Meet Portia, a Roman woman experiencing her third miscarriage around 160 CE. According to your painful experience, you are about 4 months pregnant when you start bleeding. The bleeding, according to ancient medical understanding, analysed by Dr. Fleming, is alarming, but its cause is mysterious. Ancient physicians attributed miscarriage to numerous causes: lifting heavy objects, eating the wrong foods, divine punishment, being frightened by loud noises, the womb being too slippery to hold the pregnancy. Think about what you are experiencing physically. According to modern medical understanding, you are having strong uterine contractions to expel the pregnancy, experiencing pain similar to labour, bleeding heavily, possibly developing fever if tissue is retained and becomes infected. But according to ancient medical knowledge, there is confusion about what is happening and what to do. Some physicians, according to Soranus's recommendations, advised bed rest and binding the abdomen. Others recommended herbal preparations to strengthen the womb. Most treatments, according to modern analysis, were ineffective. According to the emotional impact documented in epitaphs and literary sources, Roman women grieved miscarriages deeply. You've lost 3 potential children now. You wonder if you are cursed, if you've offended the gods, if your body is fundamentally broken. According to Roman beliefs analysed by Dr. Fleming, repeated miscarriages might be seen as divine displeasure or as evidence of some spiritual or moral failing. The blame, according to these frameworks, fell on you rather than on chance, genetic factors or medical conditions that ancient medicine couldn't identify. Stillbirth, according to ancient sources, was heartbreaking and dangerous. Meet Domitia, a Roman woman who has carried a pregnancy to full term but delivered a baby who didn't survive, around 175 CE. According to your experience, Labor proceeded normally for hours. The midwife seemed satisfied with your progress. But when the baby emerged, according to the terrible reality, the infant was lifeless, blue, unresponsive, never drawing breath. Think about this moment. According to the emotions documented in funerary inscriptions analysed by Dr. Maureen Carroll, you've endured hours or days of agonizing labor, risked your life in childbirth, only to have no living baby at the end. The grief, according to ancient sources, was profound. You'd felt the baby moving inside you for months. You'd prepared for this child, imagined this child's future, endured pregnancy discomforts anticipating the reward of a living infant. Now you face empty arms and the physical recovery from childbirth, without a baby to nurse. According to Roman practices, stillborn infants received different burial treatment than infants who'd lived even briefly. Some, according to archaeological evidence, were buried under house floors or in gardens rather than in cemeteries. The religious and social status of stillborn babies was ambiguous. Not quite persons, not quite nothing. You face not only grief, but also uncertainty about how to mourn, how to mark this loss, whether this child had a soul that needed remembering. Now, let's examine a complication that ancient medicine recognized but couldn't treat. Eclampsia, the development of seizures during pregnancy or labor. According to modern obstetric knowledge, eclampsia results from dangerously high blood pressure during pregnancy, causing seizures that can be fatal to both mother and baby. Ancient physicians, according to Dr. Helen King's research on ancient gynecology, recognized this syndrome but attributed it to various incorrect causes. Meet Flavia, a Roman woman in late pregnancy who begins experiencing symptoms around 190 CE. According to your frightening experience, you've developed severe headaches, seeing spots before your eyes, swelling in your hands and face. Ancient physicians, according to Serranus's descriptions, might recognize these symptoms as serious but wouldn't understand their connection to blood pressure. They might prescribe bloodletting, herbal remedies, or rest, none of which, according to modern medical knowledge, effectively treats preeclampsia or prevents its progression to eclampsia. Then, according to the terrifying reality, you have a seizure. Your body convulses uncontrollably. You lose consciousness. The women attending you panic, not knowing what is happening or how to help. Ancient medical texts, according to Dr. King's analysis, described these seizures but couldn't explain them. Some attributed them to divine possession, others to the womb wandering to the brain, still others to imbalances of bodily humours. According to modern obstetric knowledge, the only effective treatment for severe preeclampsia or eclampsia is delivering the baby, often by emergency caesarean section. But in the ancient world, according to medical capabilities, there was no safe way to surgically deliver a baby from a living woman. The caesarean section, according to its name derived from Roman law, lex caesarea, was performed only after maternal death to attempt to save the baby. If you survived your seizures, it was by chance, not because of medical intervention. Let's talk about a devastating consequence of difficult childbirth that could leave women suffering for the rest of their lives: obstetric fistulas. According to modern medical understanding, a fistula is an abnormal opening between organs, and obstetric fistulas typically connect the vagina to the bladder or rectum. They develop when prolonged obstructed labor causes tissue death from pressure, creating holes that allow urine or feces to leak uncontrollably through the vagina. Meet Antonia, a young Roman woman who survived a horrific labor but now faces a lifetime of suffering. Around 165 CE, according to your devastating experience, you were in labor for 4 days with your first baby. The baby was too large, positioned wrong, couldn't fit through your pelvis. Eventually, after days of pushing, the baby was born dead and you survived, but with terrible injuries. According to the physical reality, analysed in modern obstetric literature, the prolonged pressure during your obstructed labour killed patches of tissue in your birth canal, bladder and rectum. Think about your life now, according to the horrific reality. You constantly leak urine. The smell is overwhelming, inescapable. You can't control it, can't stop it. According to descriptions in later medical texts analysed by historians, women with fistulas were often socially isolated. You smell of urine constantly. You can't participate in social occasions, can't visit temples. You are ritually impure. Can't maintain normal family relationships. Your husband, according to Roman legal and social options, might divorce you because of this condition. Ancient physicians, according to Serranus's gynecological texts, recognized fistulas, but had extremely limited ability to repair them. The surgical techniques for fistula repair, according to Dr. Fleming's research, were attempted occasionally but with very poor success rates and tremendous pain for the patient. Without effective surgery, according to the terrible reality, you'll live like this for the rest of your life. Decades of constant leaking, burning skin where urine flows continuously, social isolation, shame, and physical misery. All this because you tried to have a baby, because you survived labor that killed your child, because ancient medicine couldn't perform a caesarean section that would have saved you both. According to modern global health data, obstetric fistulas still afflict women in regions without access to emergency obstetric care. Understanding this ancient complication, according to medical historians, reminds us that childbirth complications don't just kill, they can create lifetime suffering for survivors. Now, let's explore twin pregnancies, because carrying and delivering multiple babies was even more dangerous than singleton pregnancy. According to modern obstetric data, twin pregnancies have higher rates of every complication: preterm labor, hemorrhage, abnormal presentations, maternal death. In the ancient world, according to demographic research, the risks were correspondingly higher. Meet Calpurnia, a Roman woman pregnant with twins around 180 CE. According to your experience, your abdomen is enormous, larger than other women at similar stages of pregnancy. The midwife, according to her assessment, believes you are carrying twins. This news, according to Roman cultural attitudes documented by Dr. Dasson, brings both excitement and fear. Twin births were seen as special, sometimes auspicious, sometimes ominous, always dangerous. Think about the physical burden. According to modern understanding of twin pregnancy, you are carrying extra weight, experiencing more severe pregnancy symptoms, more fatigued, more uncomfortable. Your body is working harder to support two developing babies. You are at higher risk of developing anemia, preeclampsia, and premature labor, and ancient medicine, according to its limitations, can't effectively treat any of these conditions. When labor begins, according to the particular dangers of twin delivery, complications multiply. The first baby might deliver normally, but the second could be positioned wrong, might become stuck, might lack adequate placental circulation after the first baby is born. Ancient midwives, according to Serranus's descriptions of twin delivery, knew to expect two babies and knew some techniques for delivering the second baby. But their options were limited. According to your experience, the first baby delivers successfully, but the second baby, according to the terrifying complication, is positioned sideways across your uterus. The midwife reaches in, trying to reposition the baby, causing excruciating pain. Hours pass. You are exhausted from delivering the first baby, bleeding heavily, weakening. The second baby finally emerges, but according to the tragic reality, is stillborn, and you are hemorrhaging severely. According to ancient medical capabilities, there is little that can save you now. Let's examine pregnancy in ancient China, because Chinese medical traditions developed different theoretical frameworks and different practices from Western medicine. According to research by Dr. Charlotte Firth on Chinese medicine and women's bodies, Chinese medical texts included detailed discussions of menstruation, pregnancy, and childbirth within their theoretical system, based on qi vital energy and yin-yang balance. Meet Mei, a woman in Han Dynasty China around 100 CA about to give birth. According to Chinese medical understanding, as documented in texts like the Huangdi Neijing, your pregnancy and approaching labor are understood in terms of energy flows, balance of yin and yang qualities, and the relationship between your body and cosmic forces. The midwife attending you, according to her training in traditional techniques, uses methods passed down through generations of Chinese midwives. According to Dr. Firth's research, Chinese medical texts recommended specific birthing positions, breathing techniques, and herbal preparations different from those in Western traditions. Ginseng, according to Chinese medical theory, could strengthen qi and help during difficult labor. Various other herbs from the Chinese pharmacopoeia were used for different pregnancy and childbirth situations. Some of these, according to modern pharmacological analysis, contained active compounds that might have provided genuine benefits, while others were therapeutically inert. But according to the fundamental limitations, Chinese medicine faced the same ultimate constraints as Western ancient medicine. Without understanding of germ theory, without surgical capabilities for emergency delivery, without blood transfusions or effective medications for hemorrhage, Chinese women died from childbirth complications at rates similar to women elsewhere in the ancient world. Different theoretical frameworks and different herbal traditions couldn't overcome the basic physiological dangers of pregnancy and childbirth in pre-modern conditions. According to Chinese cultural practices documented in historical sources, childbirth occurred in female space with female attendants, similar to other ancient cultures. Women burned incense, invoked protective deities or ancestors, used traditional objects believed to have protective power. The emotional experience, the fear, the pain, the hope, the grief when things went wrong transcended cultural differences. Chinese women, like Roman women, like Egyptian women, faced childbirth knowing they might not survive. Let's explore ancient Indian medical traditions, because Ayurvedic medicine developed sophisticated gynecological and obstetric knowledge. According to research by Dr. Kenneth Zisk on ancient Indian medicine, texts like the Sushruta Samhita and Charaka Samhita included detailed sections on women's reproductive health, pregnancy care, and childbirth management. Meet Priya, a woman in ancient India around 300 CA preparing for childbirth. According to Ayurvedic medical understanding documented in Sanskrit texts, your pregnancy has been understood in terms of dosha balance, vata, pitta, and kapha. The midwife attending you, according to her Ayurvedic training, has recommended specific dietary practices, herbal preparations, and lifestyle modifications throughout your pregnancy to maintain proper balance. According to the Sushruta Samhita's detailed descriptions, analysed by Dr. Zisk, ancient Indian physicians recognized numerous pregnancy complications and difficult childbirth presentations. The text describes procedures for managing abnormal fetal positions, techniques for embryotomy when necessary, and herbal medicines for various conditions. Some recommendations, according to modern analysis, show genuine empirical observation, recognizing warning signs, understanding that certain interventions increased risk, knowing when to intervene and when to wait. Ancient Indian medical texts, according to Dr. Zisk's research, also described surgical procedures including caesarean section. However, according to historical evidence, these were likely performed primarily on deceased mothers to attempt to save the baby, similar to Roman practice. The challenge of performing abdominal surgery on a living woman without anesthesia, antisepsis, or ability to control bleeding remained insurmountable, regardless of theoretical knowledge. According to your childbirth experience, you labor attended by a trained dai, traditional midwife, female relatives, and with the support of prayers and rituals. The dai knows massage techniques, positioning, herbal preparations. She is experienced, skilled within the limitations of ancient knowledge, but according to the same fundamental constraints faced everywhere in the ancient world. If you develop a serious complication, severe hemorrhage, eclampsia, completely obstructed labor, The outcome likely depends more on chance than on medical intervention. Now let's discuss the long-term health consequences for women who survived childbirth complications. According to modern medical understanding, traumatic births can cause lasting physical and psychological effects. In the ancient world, according to the absence of reconstructive surgery and long-term medical care, women often lived with serious disabilities resulting from childbirth injuries. Meet Julia, a Roman woman who survived a difficult birth 10 years ago but still suffers from its consequences around 185 CE. According to your experience, you tore severely during delivery. The midwife stitched the tears with thread, but according to the healing process, you developed terrible scarring. Sexual intercourse, according to your ongoing reality, is painful. You've had chronic pelvic pain for a decade. You've had several infections in the years since, causing fever, discharge, and worsening pain. According to modern medical understanding of birth injuries, you probably have nerve damage, poorly healed tears, possibly some degree of pelvic organ prolapse, all conditions that ancient medicine couldn't properly diagnose or treat. You've learned to live with chronic pain, accepted it as the permanent price of motherhood. According to Roman cultural expectations, you don't complain. You manage your household, care for your surviving children, and endure the daily discomfort that started with their births. Think about the psychological toll. According to modern research on birth trauma by Dr. Cheryl Beck, difficult births can cause symptoms of post-traumatic stress, flashbacks, nightmares, anxiety, depression. In the ancient world, according to the absence of psychological medicine, women processed trauma without therapy, without psychiatric care, without even vocabulary to describe their psychological suffering. You have nightmares about the labor. You panic when you learn of another pregnancy. You are terrified for your daughters when they marry, knowing they'll face the same dangers you survived. According to research by Dr. Sarah Pomeroy on ancient women's lives, women developed their own support systems for processing trauma. You talk with other women who survived difficult births. You share your fears and experiences in female spaces, at the fountain where you draw water, at the baths, during religious ceremonies for women. These conversations, according to anthropological understanding of social support, provided crucial emotional processing, even if they couldn't change medical realities. Let's examine the experience of very young mothers, because girls in many ancient cultures married and became pregnant in their early teens. According to modern medical knowledge, pregnancy in very young teenagers carries higher risks. The pelvis isn't fully grown, the body isn't fully mature, complications are more common. In the ancient world, according to demographic research by Dr. Walter Scheidel, girls often married around age 12 to 15 and might become pregnant immediately. Meet Claudia, a girl in ancient Rome who married at age 13 and is now pregnant at 14 around 170 CE. According to your physical reality, you are still growing yourself. Your pelvis, according to modern understanding of skeletal development, isn't finished expanding. Your body, according to biological maturity, isn't optimally ready for pregnancy. But according to Roman social customs, you are considered ready for marriage and motherhood because you've begun menstruating. Think about your experience. According to the fears you face, you've heard stories of girls dying in childbirth. You know several girls from your neighborhood who didn't survive their first pregnancies. Your mother, according to her attempts to prepare you, has told you about labor pain, about the dangers, about the need to be brave. But according to the reality of your age, you are still essentially a child, facing an adult woman's most dangerous experience. When labor begins, according to the particular risks of adolescent childbirth, complications are more likely. Your pelvis might be too small for the baby to pass through. You might suffer worse tearing because your tissues are less mature. According to modern obstetric data, teen mothers under 15 have significantly higher maternal mortality rates than women in their 20s. And this was even more pronounced in the ancient world, without modern medical intervention. According to your outcome, you survive, but barely. The labour lasted 3 days. You tore severely. You hemorrhaged, but the bleeding eventually stopped. Your baby survived, but is small, weak, crying constantly. You are exhausted, in pain, and now responsible for keeping an infant alive when you are barely more than a child yourself. According to the reality for many young mothers in ancient Rome, this is just the beginning of a life that might include many more dangerous pregnancies, many more births, possible widowhood while still young, and all the challenges of ancient women's existence compressed into a life that began adult responsibilities far too early. Now let's talk about pregnancy spacing and the fact that ancient women often faced pregnancy after pregnancy with minimal recovery time between them. According to modern medical understanding, closely spaced pregnancies increase risks. The mother's body hasn't fully recovered nutritionally and physically before the next pregnancy begins. In the ancient world, according to demographic patterns, women who survived to their 30s might have been pregnant or nursing almost continuously throughout their 20s. Meet Aurelia, a Roman woman in your late 20s who has been pregnant or nursing almost constantly for the past decade around 180 CE. According to your experience, you've had 6 pregnancies in 10 years. 3 children survived, 2 were stillborn, 1 died in infancy. You are currently pregnant again. According to your physical condition, you are exhausted. You are probably anemic from repeated pregnancies and blood loss. Your bones, according to modern understanding of pregnancy's nutritional demands, have been depleted of calcium. You are worn down, aged beyond your years. Think about what continuous pregnancy does to your body. According to modern medical knowledge, each pregnancy draws on your nutritional stores. Your bones provide calcium for the developing baby. Your blood volume expands then contracts. Your abdominal muscles stretch repeatedly. Your pelvic floor endures multiple births. Without adequate recovery time, without proper nutrition to rebuild your reserves, your body becomes progressively more depleted. According to Dr. Walter Scheidel's demographic research, this pattern rapid, repeated pregnancies was common in the ancient world, at least among women who survived their early births. Breastfeeding, according to its contraceptive effects, provided some spacing between pregnancies, but not reliably. Women who couldn't or didn't breastfeed might become pregnant again within months of giving birth. The cumulative toll, according to the physical evidence from ancient skeletal remains analysed by bioarchaeologists, shows in bones weakened by calcium depletion, pelvises marked by multiple births, bodies aged prematurely by the demands of continuous reproduction. Let's explore how ancient societies tried to prevent pregnancy, because women desperate to avoid continuous dangerous pregnancies did attempt contraception and abortion. According to research by Dr. John Riddle on ancient contraceptive practices, various herbal preparations were believed to prevent pregnancy or cause early miscarriage. Some of these, according to modern pharmacological analysis, might have had weak contraceptive or abortifacient effects, while others were useless or dangerous. Meet Secunda, a Roman woman who has survived 3 difficult births and desperately doesn't want another pregnancy, around 175 CE. According to your situation, you've heard from other women about herbs that might prevent pregnancy: silphium, pennyroyal, various roots and seeds. Silphium, according to ancient sources analysed by Dr. Riddle, was particularly valued as a contraceptive and was traded so extensively that it may have been driven to extinction. Pennyroyal, according to modern pharmacological knowledge, can induce miscarriage but is also toxic and can cause liver damage or death. Think about the choices you face. According to Roman law and social attitudes, there were no legal restrictions on abortion in early pregnancy. The fetus wasn't considered a person with legal status until birth, but according to the practical realities, the methods available were dangerous, unreliable, and often ineffective. You might drink herbal preparations that make you violently ill without ending the pregnancy. You might try physical methods, vigorous exercise, abdominal massage, hot baths. That also rarely worked and sometimes caused harm. According to your desperate decision, you try pennyroyal tea despite warnings from other women about its dangers. According to what happens, you become terribly sick, vomiting, abdominal pain, dizziness. But according to the outcome, you are still pregnant. The herb made you miserable without accomplishing its intended purpose. Now you face your fourth pregnancy weakened by the poisoning attempt, still carrying the pregnancy you desperately wanted to avoid. This pattern, according to historians studying ancient contraceptive attempts, was common. Women caught between dangerous repeated pregnancies and dangerous ineffective contraceptive methods had few good options. The herbal remedies that might work were often toxic. The barrier methods mentioned in ancient sources, cloths soaked in various substances inserted into the vagina, were unreliable. Abstinence within marriage was rarely practical, and women typically had no power to refuse their husbands. According to the grim reality, most married women simply faced pregnancy after pregnancy, hoping to survive, grieving the babies who died, and enduring the toll on their bodies. Now let's discuss the seasonal variations in pregnancy and childbirth outcomes, because ancient women's experiences varied with the time of year. According to research by bioarchaeologists analysing seasonal mortality patterns, winter births in cold climates had higher mortality rates, while summer births in hot climates faced different challenges. Meet Livia, a woman in Roman Britain giving birth during harsh winter around 230 CE. According to your circumstances, you are delivering in a small, cold dwelling. Heating, according to the reality of Roman Britain's climate and limited fuel resources, is inadequate. The midwife and attending women are cold. The baby, according to the danger of winter birth, will emerge into a cold environment. According to modern understanding of newborn temperature regulation, infants are vulnerable to hypothermia, and warming a tiny baby in a cold ancient dwelling was challenging. According to the infection risks, winter's crowded indoor conditions with poor ventilation increased exposure to respiratory illnesses. If you or the baby developed infection in the days after birth, according to your weakened postpartum state and the baby's immature immune system, the outcomes could be fatal. The death rates for winter births, according to skeletal evidence analysed by bioarchaeologists, show elevated mortality during the coldest months. Summer births in hot climates faced different dangers. Meet Demetria, a woman in Egypt giving birth during intense summer heat around 250 CE. According to your experience, you are labouring in stifling heat, sweating profusely, becoming dehydrated. The midwife, according to her practices, gives you water to drink, but according to the risk of waterborne illness, the water itself might make you sick. Flies, according to the reality of ancient Egyptian summers, swarm everywhere, landing on you, on the baby when delivered, on any open wounds or blood. According to the infection risks analysed by modern epidemiologists studying historical disease patterns, summer heat meant faster bacterial growth, more insects spreading pathogens, higher rates of gastrointestinal infections. A baby born in Egyptian summer, according to demographic evidence, faced immediate risks from heat stress, dehydration, and the infections that killed so many infants in their first weeks of life. You survived the dangerous delivery, but now you face keeping your newborn alive through the deadly summer season. Before we conclude, let's examine the experience of enslaved women in the ancient world, because their reproductive experiences carried additional layers of vulnerability and suffering. According to research by Dr. Sandra Jushel on Roman slavery, enslaved women had no control over their own bodies, faced sexual exploitation by owners, and endured pregnancy and childbirth in conditions of bondage. Meet Fortunata, an enslaved woman in ancient Rome, pregnant with her third child around 165 CE. According to your circumstances, you don't know who fathered this pregnancy. It might be your master, might be another enslaved person, might be a result of rape by someone visiting the household. You have no choice in the matter. According to Roman law, enslaved women's bodies belong to their owners, and resistance to sexual demands could mean brutal punishment or death. Think about your situation facing childbirth. According to the economics of Roman slavery, analysed by Dr. Keith Bradley, you represent financial investment, your owner. Your ability to produce more enslaved children has monetary value. But according to the harsh reality, your owner has no real incentive to provide good medical care. If you die, the owner loses one worker but gains an infant who will eventually become a worker. The calculation, according to this brutal logic, doesn't favour protecting your life. According to your experience, you labour attended by other enslaved women, possibly by a midwife if your owner considers you valuable enough. You have no right to refuse work until late in pregnancy. You've been doing heavy physical labour, carrying water, washing clothes, grinding grain until days before delivery. According to your exhausted, malnourished condition, you are more vulnerable to complications than free women who could rest in late pregnancy. When labour begins, according to the terrifying reality, you are alone except for other enslaved women. No family members attend you. You were sold away from your mother years ago. Your children from previous pregnancies were sold to other owners. You have no husband because enslaved people couldn't legally marry. If you die according to Roman practices, you'll be buried in a mass grave for enslaved people, unmarked, forgotten. Your baby, if it survives, will be enslaved from birth. According to epitaphs for enslaved women who died in childbirth, analysed by Dr. Maureen Carroll, some show genuine grief from fellow enslaved people, or even from owners. But many enslaved women who died in childbirth left no trace, no memorial, no record except possibly a notation in household accounts about a financial loss. Their suffering and death, according to historical erasure, barely registered in societies that didn't consider enslaved people fully human. Let's examine another dimension of ancient reproductive experiences. What happened when women couldn't produce living children? According to Roman and Greek social expectations, a woman's primary value was producing legitimate heirs, particularly sons. Infertility or repeated pregnancy losses, according to these frameworks, could have devastating consequences. Meet Cornelia, a wealthy Roman woman who has been married for 8 years but has no living children, around 180 CE. According to your painful history, you've had 5 pregnancies. 2 ended in early miscarriage, 2 ended in late miscarriage or stillbirth. 1 baby lived for 3 days before dying. According to your desperation and grief, you are considered a failure as a wife, despite your social status and wealth. Think about the social pressure you face. According to Roman marriage patterns, your husband could divorce you for failing to produce heirs. In fact, according to Dr. Susan Treghieri's research on Roman marriage, infertility was considered grounds for divorce. And the assumption was always that infertility was the woman's fault, never the man's. You face the possibility of being sent back to your father's house in disgrace, losing your position, seeing your husband remarry a younger woman who might succeed where you failed. According to the medical treatments available, you've tried everything ancient physicians suggested. You've taken endless herbal concoctions. You've undergone fumigations that burned and irritated your vaginal tissues. You've had physicians prescribe bloodletting to balance your humours. You've prayed at temples, made offerings to fertility goddesses, carried amulets, performed rituals. Nothing, according to the tragic reality, has changed your outcome. You keep conceiving but can't carry a pregnancy to produce a living child. According to modern medical understanding, you might have any number of conditions, repeated chromosomal abnormalities, hormonal disorders, uterine structural problems, incompetent cervix, autoimmune disorders. Ancient medicine, according to its fundamental limitations, couldn't diagnose or treat any of these conditions. All the physicians could do was blame you. Your womb was too cold, too wet, too slippery, improperly positioned. The fault, according to ancient medical frameworks, lay in your defective female body. Now let's explore the wet nursing system. Because wealthy women who survived childbirth often hired other women to breastfeed their babies. According to research by Dr. Valerie Filders, wet nursing was common in many ancient cultures, creating a system where poor women's bodies were used to nourish wealthy women's children, often at the expense of the wet nurse's own baby. Meet Volumnia, a poor Roman woman who has become a wet nurse to supplement your family's inadequate income around 170 CE. According to your circumstances, you delivered a healthy baby 3 months ago. Your own baby died last month, officially from fever. But according to the cruel reality, probably from malnutrition, because you were nursing your employer's baby and had insufficient milk for both. Think about your situation. According to the wet nursing contract analysed by historians, you are paid to nurse a wealthy merchant's infant. The payment, according to your family's desperate financial state, is necessary for survival. But according to the terrible choice this forces, you must prioritize your employer's baby over your own. The wealthy baby gets fed whenever hungry. Your baby had to wait, got less milk, weakened, became vulnerable to illness, died. According to the grief and guilt you carry, you killed your own child to feed someone else's. But according to the economic realities of Roman poverty, you had no real choice. Your family needed the money. Your husband's sporadic work as a day labourer doesn't feed your other children. The wet nursing income, according to your calculations, saves more lives than it costs. The payment feeds your older children who would otherwise starve. According to the physical toll, wet nursing is exhausting. You are constantly feeding someone else's baby while pregnant again yourself. Women who could become pregnant often did wet nursing because pregnancy wouldn't immediately stop milk production. You are depleted, malnourished, grieving your dead baby while nourishing another woman's living child. According to the social dynamics documented by Dr. Fields, this system created complex relationships between wet nurses and the families they served. Sometimes affection developed, but underlying the relationship was always exploitation. Let's discuss placenta previa, another dangerous complication that ancient medicine recognized but couldn't treat. According to modern obstetric knowledge, placenta previa occurs when the placenta covers the cervical opening, making vaginal delivery impossible because the placenta blocks the baby's exit and causes catastrophic hemorrhage when labor begins. Meet Sabina, a Roman woman in late pregnancy whose placenta is positioned over her cervix, around 190 CE. According to the warning signs, you've been experiencing bleeding throughout the second half of pregnancy. The midwife, according to her assessment, knows something is seriously wrong but can't determine exactly what. Ancient practitioners, according to Serranus's descriptions, recognized that some women bled during pregnancy without losing the pregnancy, and they knew this could signal danger during delivery. When labor begins, according to the catastrophic reality, you immediately start hemorrhaging severely. The bleeding, according to modern understanding of placenta previa, comes from the placenta tearing away from the uterine wall as the cervix begins to dilate. The baby can't descend because the placenta blocks the way. You are bleeding massively, losing blood faster than anyone can comprehend. According to the midwife's desperate attempts, she tries to reach inside to remove what she thinks might be placental tissue blocking the baby. This, according to modern obstetric knowledge, makes the hemorrhage worse, causing more placenta to separate, increasing the bleeding. Ancient medicine, according to Dr. Fleming's research, had no concept of placenta position as a cause of bleeding, and no way to treat it, even if they had understood. According to the outcome, you bleed to death within an hour of labour starting. The baby dies as well, never having a chance to be born. Your last moments, according to the horror documented in ancient medical accounts of similar cases, are filled with terror and pain as you feel your life draining away. The women attending you can only watch helplessly, knowing nothing they do will stop the bleeding. Modern medicine, according to current obstetric practice, easily diagnoses placenta previa through ultrasound and treats it with scheduled caesarean section before labour begins, saving both mother and baby. In the ancient world, according to the tragic reality, this condition was a death sentence. Now, let's examine the experience of women who had previous caesarean sections attempted, though these were nearly always fatal in the ancient world. According to Dr. Osei Temkin's analysis of Soranus's texts, caesarean section on living women was occasionally attempted in desperate circumstances, though survival was extraordinarily rare. Meet Sempronia, a Roman woman on whom physicians are about to attempt caesarean section around 185 CE. According to your dire situation, you've been in obstructed labour for 5 days. The baby is clearly dead, no movement, terrible odour, indicating decomposition has begun. Embryotomy, according to the physician's assessment, is impossible because the baby is positioned in a way that can't be reached with hooks and knives. Your only hope, according to this desperate calculation, is surgical removal through your abdomen. Think about what you are about to experience. According to the medical capabilities, you'll be conscious or at most given wine mixed with opium, nowhere near enough to dull the pain of abdominal surgery. The physician, according to his training, will cut through your abdominal wall, through the layers of muscle, into your uterus. The pain, according to descriptions from the rare survivors of ancient surgery documented by historians, is beyond anything humans are meant to endure. According to the procedure, the physician cuts quickly, removes the decomposing baby, pulls out the placenta. You are screaming, probably being held down by multiple people. Blood flows freely. Ancient surgeons had no way to cauterize blood vessels, no clamps to stop bleeding, no ability to suture effectively. According to Dr. Temkin's analysis, the surgeon would try to stitch the uterine incision and abdominal wall, but the stitching techniques were crude, the materials were non-sterile, and infection was virtually inevitable. According to the most likely outcome, you die within hours from blood loss, or within days from septic infection. The rare women who survived ancient caesarean sections, according to historical accounts, were considered miraculous. Most, according to the medical realities, died screaming in agony, their abdomens cut open, internal organs exposed, experiencing pain that should never have been inflicted on conscious humans. Let's explore religious responses to the dangers of childbirth, because across cultures women turned to gods and goddesses for protection that human medicine couldn't provide. According to research by Dr. Vethert number 233, Ronique Dasson on birth iconography, virtually every ancient culture had deities associated with childbirth and fertility, and women's devotion to these deities was intense and personal. Meet Octavia, a Roman woman preparing for your first childbirth around 175 CE. According to your religious practice, you've been making offerings at the temple of Juno Lucina, the goddess who brings babies into the light. You've purchased a small clay figurine of the goddess, which will stay with you during labour. You've had your female relatives bring you a sacred girdle that has been blessed at the temple. You've prayed, made vows about what you'll offer if you survive. Think about why religion matters so much in this moment. According to the reality you face, human medicine offers very little real help. Midwives can catch the baby and cut the cord, but they can't save you if serious complications develop. Physicians have some techniques, but nothing that reliably prevents death. In the face of this helplessness, according to anthropological understanding of religious practice in crisis situations, turning to divine powers provides both hope and a sense of some control over the uncontrollable. According to your prayers, you are not asking for an easy labour. You know from other women that labour is supposed to hurt, that it is Eve's curse, that suffering is expected. What you are praying for, according to the specific wording of vows, documented in temple dedications analysed by historians, is survival. You promise Juno offerings if you live through this. You promise to name a daughter after the goddess. You promise annual gifts to the temple. You are bargaining for your life with divine powers because human powers have so little to offer. After you survive, according to Roman religious practices, you'll make good on your vows. You'll bring the promised offerings to Juno's temple. You'll commission a small dedication acknowledging the goddess's protection. These dedications, according to archaeological evidence, survive in the archaeological record small plaques, figurines, inscribed stones left by women grateful to have survived childbirth. Each one, according to modern understanding, represents a woman who beat the terrible odds. Now let's examine the practice of exposure, abandoning newborns who weren't wanted or couldn't be supported. According to research by Dr. Sarah Pomeroy and Dr. Keith Bradley on child abandonment in the ancient world, exposing unwanted infants was legal and relatively common, particularly for girls, sickly babies, or children born into poverty. Meet Lucia, a poor Roman woman who has just given birth to her fifth daughter around 160 CE. According to your desperate circumstances, you can barely feed the children you already have. Your husband, according to his harsh decision, has told you this baby must be exposed. You can't keep another daughter, can't afford another mouth to feed, can't provide dowry for another girl to marry. Think about what you are about to do. According to Roman law and social practice, newborn infants weren't legally considered persons until they'd been accepted by the head of household. If the father refused to accept the baby according to legal frameworks, it could be exposed, left outside to die of exposure, or possibly be picked up by someone else, who might raise it as a slave or prostitute. According to your task, you'll take the baby, this tiny girl who has committed no crime except being born female and poor, and leave her in a designated spot where unwanted babies are abandoned. Maybe, according to the small hope you cling to, someone will find her and take her in. More likely, according to the grim reality, she'll die of exposure within hours, or animals will get her, or she'll be picked up by slave traders who'll raise her for prostitution. According to the emotional toll, this destroys you. You carried this baby for 9 months. You felt her moving inside you. You endured labor pain to bring her into the world. Now, according to economic realities you can't change, you must kill her through abandonment. The grief, according to literary sources that occasionally mention mothers' feelings about exposure, is terrible. But, according to the brutal calculus of poverty, you are choosing which children live and which die, and keeping this baby might mean all your children starve. Ancient societies, according to demographic analysis by Dr. Walter Scheidel, lost significant numbers of infants to exposure, contributing to the already terrible infant mortality rates. The practice, according to Roman and Greek sources, was discussed matter-of-factly without the moral horror modern people might feel. It was considered a practical response to poverty, illegitimacy, disability, or simply having too many daughters. Let's discuss maternal death in its immediate aftermath. What happened to the family when a mother died? According to research by Dr. Suzanne Dixon on Roman families and Dr. Barbara Hinault on medieval families, a mother's death created immediate practical crises that affected everyone in the household. Meet Marcus, a Roman man whose wife Sempronia has just died in childbirth, leaving you with a surviving newborn and 3 older children, around 75 CE. According to your immediate situation, you must arrange Sempronia's funeral while figuring out who will care for your newborn and older children. The baby, according to its need for constant feeding, must either have a wet nurse immediately or will die within days. Think about the decisions you face. According to your options, you could hire a wet nurse, expensive, requires finding a woman with milk to spare, brings a stranger into your household. You could give the baby to relatives who might care for it, essentially sending your child away permanently. Or you could expose the baby, letting it die, reasoning that Sempronia died bringing it into the world, and you can't afford to keep it anyway. According to the older children, they've just lost their mother, the person who cared for them daily, fed them, comforted them, kept the household running. According to your own grief, you've lost your wife, possibly a woman you loved, certainly your domestic partner who managed the household. But according to Roman social expectations, you are expected to remarry relatively quickly because you need a woman to run the household, care for the children, and produce more children to continue your family line. According to the remarriage patterns documented by Dr. Dixon, widowers typically remarried within a year or two. The new wife, according to her position, would become stepmother to children who might resent her replacing their mother. The family dynamics, according to the complex reality, included grief, adjustment, possible conflict between stepmother and stepchildren, and the practical necessities of household management. For the motherless children, according to the outcomes documented in demographic research, their chances of survival decreased significantly. Mothers, according to their primary caregiving role, protected children's health through nursing, feeding, basic medical care, and constant attention. Stepmothers, according to the reality of blended families, might not provide the same level of care, particularly if they began having their own children. Motherless children, according to demographic patterns, showed higher mortality rates than children with living mothers. Now, let's return to menstruation one more time, because we should explore the experience of women with particularly heavy or painful periods, conditions we now call menorrhagia and dysmenorrhea. According to modern gynecological knowledge, numerous conditions cause abnormally heavy or painful periods: fibroids, endometriosis, adenomyosis, hormonal disorders. Ancient women suffered from all these conditions without diagnosis or effective treatment. Meet Fausta, a Roman woman whose periods are so heavy and painful that you are incapacitated for a week each month. Around 180 CE, according to your monthly ordeal, you begin bleeding so heavily that you soak through your linen cloths within hours. The pain, according to your experience, feels like something inside is tearing apart. You vomit from the pain. You sometimes faint. For 7 days each month, you can barely function. Think about what this does to your life. According to the monthly cycle, you lose a quarter of your days to this condition. You can't do normal work during your periods. You can't participate in social activities. You are pale, weak, probably severely anemic from the blood loss. According to your desperate attempts to find help, you've consulted physicians who've told you your womb is diseased, your humors are imbalanced, you are being punished by gods. According to the treatments you've tried, physicians have prescribed bloodletting, removing more blood from someone already losing too much blood. They've given you astringent herbs meant to reduce bleeding, which don't work. They've suggested fumigations, pessaries, dietary changes. Nothing, according to the results, makes any meaningful difference. Every month, according to the terrible cycle, you face the same agonizing experience. According to modern medical diagnosis, you might have endometriosis, a painful condition where uterine tissue grows outside the uterus, or you might have fibroids, benign tumors in the uterus that cause heavy bleeding, or adenomyosis, hormonal disorders, clotting disorders. Ancient medicine, according to its limitations, couldn't diagnose any of these conditions specifically or treat them effectively. Modern medicine, according to current capabilities, has multiple treatment options from hormonal therapies to surgical interventions. You have none of these, only suffering that repeats monthly for decades. According to the cumulative impact, this condition destroys your health. You are chronically anemic, constantly fatigued, weakened by repeated blood loss. Your bones, according to modern understanding of severe anemia's effects, are weakened. Your heart has to work harder to compensate for low blood count. You are aging prematurely. Your life shortened by a gynecological condition that modern medicine could easily treat, but that ancient medicine could only document and describe without helping. Finally, let's talk about the very end of reproductive life, menopause, and what it meant for ancient women. According to modern medical understanding, menopause typically occurs in a woman's late 40s or early 50s, bringing cessation of menstruation and various symptoms. In the ancient world, according to medical texts analysed by Dr. Helen King, menopause was recognized and discussed, though greatly misunderstood. Meet Cornelia, a Roman woman in your early 50s whose periods have stopped around 185 CE. According to your experience, you've survived the reproductive years that killed so many of your peers. You've had 8 pregnancies, 5 living children survived. You've lost friends and relatives to childbirth, but you survived. Now, according to the physical changes you are experiencing, your periods have become irregular and eventually stopped. Think about how ancient medicine understood menopause. According to Hippocratic and later medical theories, menstruation served to expel harmful substances from the female body. Menopause, according to this flawed logic, meant those harmful substances could no longer be expelled, making postmenopausal women dangerously full of toxic retained blood. Physicians, according to Dr. King's research, sometimes prescribed bloodletting or purges to compensate for the ceased menstrual flow. According to your experience of menopausal symptoms, you have hot flashes that drench you in sweat, your sleep is disrupted, your mood fluctuates, you experience vaginal dryness that makes intercourse painful. Ancient medicine, according to its theoretical frameworks, attributed all these symptoms to the dangerous retention of menstrual blood and to the body becoming colder and drier with age. But according to the social benefits of reaching menopause, you are now free from the monthly inconvenience and taboos of menstruation. More importantly, according to the demographic reality, you are free from the danger of pregnancy and childbirth. You've survived the dangerous reproductive years. You can no longer die in childbirth. If you remain healthy, according to life expectancy data for women who reach their 50s, you might live another decade or 2. According to Roman social structures, postmenopausal women often gained social authority. You are now a grandmother, possibly a widow with control over property, a senior woman whose opinion carries weight in family decisions. You've survived what killed half your female peers. You've gained knowledge and experience. You've made it through, according to the simple fact of survival, the most dangerous period of being a woman in the ancient world. Now, as we approach the end of our long night exploring ancient women's experiences with menstruation and childbirth, let me share some final thoughts about what this history teaches us. We've spent hours together meeting women across millennia and continents. Egyptian Nefertari managing monthly periods with linen cloths, Greek Althea suffering under physicians who didn't understand her body, Roman Tertia facing childbirth knowing she might die, medieval Agnes delivering in a peasant cottage attended by local women, Islamic Zainab giving birth under the care of a trained midwife, but still vulnerable to complications ancient medicine couldn't address. What emerges from this comprehensive exploration is a picture of human resilience in the face of inescapable biological realities. Women experienced menstruation monthly for decades without effective pain relief, knowing their bodies were considered shameful and polluting. Women faced pregnancy and childbirth knowing each pregnancy carried significant death risk, without anesthesia, without antibiotics, without surgical interventions that could save them when things went wrong. Yet women continued, they married, they bore children, they supported each other, they developed knowledge systems and support networks. They found meaning and purpose despite danger and pain. According to the demographic realities we've discussed, every ancient and medieval woman knew multiple other women who died in childbirth. Every mother had experienced losing at least one child, probably several. The grief and trauma were universal and constant. Yet, according to archaeological, literary and artistic evidence, women found joy in their children, celebrated successful births, treasured their families, and created meaning from motherhood despite its terrible costs. This history is not just about suffering. According to feminist historians like Dr. Monica Green and Dr. Helen King, it is also about agency, knowledge, and resilience. Women developed sophisticated practical knowledge about their bodies and reproductive health. They created networks of support that sustained them through dangers that would seem unbearable to modern people. They advocated for themselves and each other within the constraints of patriarchal medical systems. They preserved knowledge across generations, passing down remedies, techniques, and wisdom from mother to daughter, midwife to apprentice. Let me share some specific historical examples that bring this history to life in poignant ways. According to epigraphic evidence tombstone inscriptions, analysed by Dr. Maureen Carroll, we can glimpse individual stories behind the statistics. There is an inscription from Rome mourning Vittoria, aged 27, who died giving birth to twins, leaving behind a grieving husband and older child. Another inscription remembers Cornelia, who died at age 18 in her first childbirth, her husband noting that she was snatched away in the flower of youth. These weren't just numbers in demographic tables. They were real women with names, families, hopes, and dreams cut short by the biological realities of ancient childbirth. According to literary sources, we occasionally get glimpses of women's experiences in their own words, or through sympathetic male observers. The Roman poet Juvenal, despite his often misogynistic writings, acknowledged the dangers women faced, writing that women endure the perils of childbirth and all the troubles of nursing. Pliny the Younger, in his letters, expressed genuine grief when his friend's young wife died in childbirth, writing about the tragedy of a vibrant young woman lost, a household plunged into mourning, a husband devastated. Ancient medical texts themselves, according to Dr. Helen King's analysis, sometimes reveal practitioners' awareness of their limitations. Soranus, despite his confident medical writing, occasionally acknowledged that some cases were beyond medical help, that sometimes women and babies died, despite the midwife's best efforts. These moments of acknowledgement, according to Dr. King, show that ancient medical practitioners understood the gap between their knowledge and the complexity of reproduction. Archaeological evidence, according to recent bioarchaeological research by Dr. Rebecca Gowland from Durham University, provides physical testimony to ancient women's reproductive experiences. Skeletal remains show evidence of maternal mortality, young women buried with fetal remains, women buried in positions suggesting they died during labour, women whose pelvises show stress from multiple births. One particularly poignant find from Roman London, according to the excavation report, was a young woman buried with her unborn baby still in her womb, both having died together, their bones intermingled in the grave for nearly 2,000 years. According to analysis of medieval cemetery evidence by Dr. Sharon DeWitt, patterns of female mortality show clear spikes in the years of prime childbearing. Women ages 20 to 35 have elevated death rates compared to men of the same age, a pattern that disappears in older age groups when women are past menopause. This demographic signature, according to Dr. DeWitt's research, directly reflects the toll of maternal mortality, creating an age of vulnerability for women that men didn't face. Let's think about specific herbal remedies one more time, because the gap between ancient beliefs and modern pharmacology reveals both the genuine observational skills of ancient practitioners and their profound limitations. According to Dr. John Riddle's exhaustive research on ancient contraceptives and abortifacients, some plants ancient women used actually contained compounds with mild hormonal or uterine effects. Willow bark, as we discussed, contains salicylic acid, similar to aspirin. Certain varieties of rue and pennyroyal do have compounds that can affect uterine contractions. Ancient women and the practitioners serving them weren't completely wrong about everything, but according to modern pharmacological standards, the effective doses of these plant compounds were difficult to achieve reliably through ancient preparation methods. The concentration of active compounds varies with growing conditions, plant age, preparation technique. A tea made from pennyroyal might have strong abortifacient effects in one batch and none in another batch from plants grown in different soil. Ancient practitioners, according to their methods, couldn't standardize doses, couldn't ensure purity, couldn't distinguish between the active compounds and the toxic compounds often present in the same plants. According to the tragic reality, this meant that remedies sometimes worked but often didn't, and when they worked it was often unclear which component of the treatment was responsible. Women might attribute survival to a lucky amulet when the herbal preparation actually helped, or blame themselves for insufficient faith when a remedy failed because the plant material lacked sufficient active compounds. The mixture of effective and ineffective, helpful and harmful, meant ancient women navigated medical treatment through dangerous trial and error with their own bodies. Think about the sensory experience of ancient childbirth, what it looked like, smelled like, sounded like. According to Dr. Veronique Dasson's analysis of birthing imagery on amulets and art, the birthing room was crowded, dim, smoky from incense or lamps. The woman on the birthing stool, according to artistic depictions, is surrounded by attending women, some holding her upright, some preparing linens, some praying. The smell, according to the physical reality, would be blood, sweat, incense, the earthy smell of amniotic fluid, possibly feces if the woman defecated during pushing, a normal part of childbirth that ancient sources rarely mentioned. The sounds, according to literary descriptions that occasionally referenced childbirth, were women's cries of pain, encouraging voices of attendants, prayers spoken or chanted, possibly music if someone was playing to help the labouring woman. When a baby was born, according to sources describing successful deliveries, there would be a moment of suspense waiting for the baby's first cry. That sound that meant the infant lived, that this delivery succeeded, that both mother and baby survived the immediate danger, even though the days and weeks ahead still carried risks. According to Dr. Dasson's research on birth iconography, some amulets show the moment of birth with the midwife catching the emerging baby, other women supporting the mother, protective deities watching over the scene. These images, according to their interpretation, served as prayers-made material. Carrying these amulets was a way to invoke divine protection, to remind the gods to guard this vulnerable moment, to hope that this birth would end in joy rather than tragedy. Let's explore how ancient medical theories about women's bodies influenced Western medicine for centuries after the ancient world ended. According to Dr. Monica Green's research on medieval medical transmission, the flawed theories of Hippocrates, Galen, and Soranus weren't corrected for over 1,000 years. Medieval European medicine, according to its sources, relied heavily on ancient texts preserved and transmitted through Islamic scholarship. This meant the erroneous ideas that women were colder and wetter than men, that the womb wandered through the body, that menstrual blood was toxic persisted into the early modern period. According to Dr. Green's analysis, these ancient theories shaped how women's bodies were understood and treated into the 18th and even 19th centuries. The idea that women were inherently pathological, that their reproductive systems made them prone to hysteria and madness, that their bodies needed controlling by medical authority. All these concepts, according to intellectual history, had roots in ancient medical theories. The medicalization of normal female bodily functions, according to feminist historians, began in ancient medical texts and continued for millennia. The transformation came, according to medical history, through multiple revolutions in understanding. Vesalius and other Renaissance anatomists, through human dissection, corrected many anatomical errors in ancient texts. William Harvey's discovery of blood circulation challenged humoral theory. The development of the microscope revealed cells and microorganisms, fundamentally changing medical understanding. The discovery of hormones in the late 19th and early 20th centuries finally explained menstruation and pregnancy in accurate biochemical terms, but according to the historical timeline, these discoveries came far too late for the countless women who lived and died under the old misunderstandings. The last woman to die from puerperal fever before antibiotics. The last woman to die from postpartum hemorrhage before transfusion became routine. The last woman to suffer through labor without effective pain relief. Each represents the end of a lineage of suffering, stretching back through all of recorded history. According to modern maternal health disparities analysed by the World Health Organization and researchers like Dr. Rupa Datt from Women in Global Health, the ancient patterns of maternal vulnerability persist in modified form today. In regions without access to emergency obstetric care, skilled birth attendants, blood transfusion capabilities, and antibiotics, maternal mortality rates remain hundreds of times higher than in wealthy nations with comprehensive medical infrastructure. Think about what this means. According to global health data, a woman in sub-Saharan Africa faces a 1 in 37 lifetime risk of maternal death, not far from ancient Roman levels. A woman in Northern Europe faces a 1 in 15,400 risk. The transformation modern medicine can achieve when its full capabilities are accessible. The difference, according to global health analysis, isn't primarily biological or genetic. It is access to the medical knowledge and technology that Western women gained through medical revolutions of the past 150 years, but that remain unavailable to millions of women worldwide. According to the tragic reality, obstetric fistulas, those devastating injuries from prolonged obstructed labour, still afflict tens of thousands of women annually in regions without access to caesarean sections. Young women living in remote areas without hospitals, girls who become pregnant before their pelvises are fully grown, women who labour for days without medical intervention. They experience what Roman women experienced, suffering that modern medicine solved but hasn't made available to everyone who needs it. Let's return to menstruation one final time to discuss how modern menstrual technology has transformed women's monthly experiences in ways that would seem miraculous to ancient women. According to research on menstrual product history, the first commercial disposable menstrual pads became available in the late 19th century. Before that, according to the historical reality, all women managed menstruation essentially the same way ancient women had, using cloth that had to be washed and reused. The transformation accelerated in the 20th century. Tampons became commercially available in the 1930s. Modern adhesive pads arrived in the 1970s and 1980s. Menstrual cups emerged as an eco-friendly alternative. Hormonal birth control, introduced in the 1960s, gave women the option to reduce or eliminate periods entirely. Modern pain relief ibuprofen and other NSAIDs that actually block prostaglandin production became available without prescription. Think about what these changes mean. According to the lived experience of modern women in wealthy nations, a painful period can be treated with medication that genuinely works, taken while using menstrual products that are comfortable, convenient, and reliable. Women can swim, exercise, work, socialize without menstruation imposing the restrictions it imposed on ancient women. The shame and secrecy have diminished, though not entirely disappeared. The experience of menstruation, according to this transformation, changed more in the 20th century than it had in the previous 20 centuries combined. But according to modern global disparities, period poverty remains a reality for millions of women and girls who lack access to affordable menstrual products, who miss school or work during menstruation, who still use cloth they must wash and reuse, who still face shame and restriction around menstruation. The modern transformation, according to its uneven distribution, hasn't reached everyone. According to the forward-looking question, what would ancient women think if they could see modern obstetric care? Imagine explaining to a Roman woman that you can see the baby moving inside the womb through ultrasound, that you can know whether it is a boy or girl months before birth, that genetic testing can identify potential problems, that caesarean sections are routine and safe. Imagine describing epidurals that actually eliminate labor pain, medications that stop hemorrhages, antibiotics that cure infections that were once death sentences. According to the gap in comprehension, ancient women might struggle to believe these claims. How could you see inside a woman's belly without cutting her open? How could you stop pain without stopping the labour itself? How could you cut through all the layers of abdomen and uterus, remove a baby, stitch everything back together, and have the woman survive and recover. These achievements, according to the scale of transformation, would seem like divine intervention, like magic, like claims too extraordinary to credit. Yet, according to the sobering reminder, even modern obstetric care isn't perfect. Women still die in childbirth in wealthy nations, though at vastly reduced rates. Complications still occur. Labor still hurts, despite available pain relief. The biological realities of pregnancy and childbirth, according to their fundamental nature, still carry some irreducible risk and difficulty even with all our medical knowledge. Let me share one more specific historical story to close this exploration. According to an inscription from Rome dated to the 2nd century CA and analysed by Dr. Maureen Carroll, a woman named Graxia Hagni died at age 22, having married at 18 and leaving behind a 4-year-old daughter. The inscription, commissioned by her grieving husband, describes her as incomparable and notes that she was taken away by cruel fate. There is no explicit mention that she died in childbirth, but according to demographic probabilities for a 22-year-old married woman with a young child, maternal mortality is the most likely cause. Think about Graxia's life. According to the chronology, she married at 18, had her daughter at around 19, and died at 22, possibly in a second childbirth, possibly from complications of pregnancy, possibly from infection following delivery. Her daughter, according to the inscription's evidence, survived a 4-year-old girl who would grow up without her mother, remembering her imperfectly or not at all. Her husband lived on to commission the memorial, preserving her name for 1,800 years, but probably remarrying to have more children and manage his household. Graxia's story, according to its representativeness, could stand for millions of ancient women whose names are lost. She lived, married, became a mother, died young, was mourned, and passed into history. Her experience of menstruation, pregnancy, childbirth, we can infer the general outlines from everything we know about ancient women's lives. But her specific experiences, her particular pains and fears and hopes, are lost to time. All that remains is her name on stone, a husband's grief expressed in formulaic phrases, a daughter who grew up without her, and the statistical likelihood that reproductive biology killed her, as it killed so many others. According to the question of what we owe to ancient women's memory, perhaps it is this: to remember that modern women's reproductive health, safety, and choices were built on millennia of female suffering and death. To recognize that the medical knowledge we take for granted was purchased at a terrible price, paid by women who had no choice but to endure. To appreciate that being alive today, with access to modern obstetrics and gynecology, represents an almost incomprehensible privilege compared to what most women throughout history experienced. And according to the ethical obligation, to work toward making modern reproductive healthcare truly universal, so that no woman anywhere faces childbirth with ancient levels of risk, so that menstruation doesn't create barriers to education or work, so that pregnancy is safe and wanted rather than dangerous and inescapable. Ancient women, according to their circumstances, had no choice but to endure. Modern women, according to our capabilities, can build a world where no woman must face what they faced. Before we finally close, let me offer one more reflection on the sheer scale of suffering we've explored tonight. According to demographic estimates by historians analysing population data, the Roman Empire at its height contained roughly 50-70 million people. Approximately half were women. Of those women, according to age distribution models, perhaps 10-15 million were in their childbearing years at any given time. Each of those women, according to average fertility patterns, faced multiple pregnancies over their lifetimes. The maternal mortality rate, as we've discussed, was approximately 1,000 to 1,500 deaths per 100,000 live births. Do the mathematics. According to these estimates, the Roman Empire alone, over its roughly 500-year existence, saw millions of maternal deaths, women dying in agony from hemorrhage, infection, eclampsia, obstructed labor, all the complications we've discussed. Expand that to the entire ancient world: Egypt, Mesopotamia, Greece, Persia, India, China, civilizations across Africa and the Americas. Then multiply across not just centuries but millennia the total number of women who died from pregnancy and childbirth complications throughout human history. According to rough calculations based on historical demographics, likely exceeds 100 million, possibly approaching a billion over the full span of human existence. Think about that number. According to its magnitude, maternal mortality throughout history represents a death toll comparable to major wars, plagues, and famines. Yet, according to historical memory, it is barely commemorated. There are no monuments to the billion women who died bringing life into the world. No national remembrance days, no memorials listing their names. They died individually, in private female spaces, their deaths considered natural and inevitable, rather than tragic and preventable. History, according to its focus, recorded wars and political changes, while largely ignoring the constant, grinding toll of maternal death. According to the gendered nature of this suffering, men throughout history have been able to reproduce without facing comparable death risk. A man's fertility, according to biological reality, carried essentially no mortality risk. Men died in wars, accidents from disease, but not from the act of reproduction itself. Only women, according to this biological asymmetry, faced death as a direct consequence of fertility. This asymmetry, according to feminist analysis by scholars like Dr. Adrienne Rich, fundamentally shaped women's lives, limiting their opportunities and defining their social value primarily through their reproductive capacity. Let me share more specific stories from the archaeological and literary record to bring individual voices to these numbers. According to epitaphs collected by Dr. Maureen Carroll, we have inscriptions like that of Primilla, who died at age 19 in her first childbirth, leaving her husband Lucius consumed with grief. There is Urbanilla, aged 25, taken from her husband in the flower of her youth while giving birth. There is Veturia, who died bringing forth twins, her inscription noting that cruel fortune took her. Each inscription, according to its formulaic language, barely hints at the individual tragedy. A young life ended, a family shattered, a woman reduced to a few lines carved in stone. According to medieval sources analysed by Dr. Barbara Hannawalt, we occasionally get more detailed glimpses. Church records note women dead in childbed. Account books, according to household records, sometimes note payments to midwives and then to priests for funerals, the juxtaposition marking another maternal death. Court records, according to legal historians, sometimes mention widowers seeking guardians for motherless children or permission to remarry. Each notation, according to its bureaucratic terseness, marks a life lost, a family changed forever. Think about the ripple effects of each maternal death. According to family structure analysis, a mother's death affected everyone in the household. Infants lost their primary source of nutrition and care. As we discussed, motherless infants had significantly elevated mortality. Older children lost their daily caregiver, protector, and educator. Husbands lost their domestic partners and often remarried, creating complex blended families. Grandparents, siblings, extended family all felt the loss. Each maternal death, according to its social impact, created waves of disruption, extending far beyond the woman herself. According to economic analysis of medieval households by Dr. Barbara Hannawalt, a mother's death could push a family into poverty. Women's household labour, cooking, cleaning, childcare, textile production, food preservation, garden management, represented significant economic value even though it wasn't paid in wages. A husband hiring servants to replace a deceased wife's labour, or a family taking in motherless children, or resources spent on wet nurses for surviving infants. all represented economic shocks to households already operating close to subsistence level. Let's explore how different ancient cultures attempted to ritualize and make sense of maternal death. According to Dr. Veronique Dasson's research on Roman funerary practices for women who died in childbirth, some evidence suggests these deaths received special recognition. Pregnant women who died, according to some sources, were buried with protective amulets, suggesting continued concern for both mother and unborn child in the afterlife. Women who died shortly after delivery, according to grave goods, were sometimes buried with items relating to their maternal identity, small toys or baby items, suggesting the role they'd barely begun to fill. According to medieval Christian interpretation, analysed by Dr. Clarissa Atkinson, women who died in childbirth occupied an ambiguous religious position. On one hand, according to theological teachings, they died fulfilling God's command to be fruitful and multiply, possibly earning spiritual merit. On the other hand, according to religious requirements, they died in a state of physical pollution from childbirth blood, technically making them ritually impure. Some medieval sources, according to Dr. Atkinson's analysis, suggested that women who died in childbirth might go straight to heaven as martyrs of sorts, while others emphasized the need for post-mortem churching rituals to purify them. According to ancient religious practices across cultures, childbirth goddesses received particular devotion precisely because of childbirth's dangers. Artemis in Greece, Juno Lucina in Rome, Taret in Egypt, various goddesses in Mesopotamia, India, China. Each culture, according to religious historian analysis, developed divine figures specifically concerned with protecting women during their most vulnerable moments. The intensity of devotion to these deities, according to anthropological interpretation, directly reflected the intensity of fear surrounding childbirth. Think about the votive offerings left at shrines of childbirth goddesses. According to archaeological finds, women left clay figurines of babies, models of wombs, carved images of swollen bellies. After successful deliveries, according to temple dedication records, women returned to fulfill vows made during labor, offerings of money, goods, animals, or service to the temple. Each offering, according to its religious meaning, represented a prayer answered, a life saved, a woman who beat the odds. The accumulation of such offerings at temples, according to their sheer number, testifies to how many women sought divine help and how many survived to express gratitude. Let me share one more dimension of this history: how the constant proximity to maternal death shaped ancient women's relationships with each other. According to anthropological research on women's networks by Dr. Froma Zeitlin and others, the shared experience of reproductive vulnerability created powerful bonds among women. Women attended each other's births, shared knowledge about managing menstruation and pregnancy, mourned each other's losses, celebrated each other's survival. These bonds, according to social analysis, were forged in literal life and death situations. The women who held you during labor, who encouraged you through hours of pain, who stood ready to help if hemorrhage or other complications arose. These women had trusted you with their lives in their own labors, and you trusted them with yours. The midwife who delivered your babies had perhaps delivered your mother, would perhaps deliver your daughters. These relationships, according to their foundation in shared vulnerability, were profound and essential. According to Dr. Helen King's research on women's medical knowledge networks, these female communities preserved practical knowledge that existed separately from, and sometimes in tension with, male medical authority. Women knew which midwives were skilled and which were dangerous. They knew which herbs genuinely helped and which were useless or harmful. They knew techniques for managing heavy bleeding, easing labor, caring for newborns. This knowledge, according to its transmission patterns, passed from mother to daughter, between friends, among women supporting each other through the universal female experiences of menstruation, pregnancy, and childbirth. But according to the historical record's gender bias, most of this women's knowledge is lost to us. Male medical writers occasionally recorded women's practices, usually with condescension toward women's superstitions. The actual content of conversations between women about their bodies, the specific knowledge shared at the fountain, or in the bath, or during labour, almost none of this, according to source Survival, was written down. We can infer its existence from references and hints, but the detailed content is largely gone, lost because the people who possessed it, poor and middling women, rarely had the literacy, resources, or social standing to record their knowledge. According to what we can reconstruct, ancient women's practical knowledge included genuine insights that male medical theory missed. Women observing their own bodies across multiple pregnancies recognized patterns that physicians studying theory didn't see. Midwives attending hundreds of deliveries developed empirical knowledge about what worked and what didn't, knowledge grounded in experience rather than humoral theory. The tragedy, according to medical historians, is how much of this practical wisdom disappeared without being preserved, lost when ancient societies failed to value and record women's experiential knowledge. As we near the end of this extraordinarily long exploration, let me emphasize once more the element of choice, or rather, the lack of choice ancient women faced. According to social structures across ancient cultures, women typically had little say in whether they married, whom they married, when sexual activity occurred within marriage, whether to use contraception, or whether to continue or terminate pregnancies. The reproductive experiences we've explored, according to their social context, happened to women rather than being choices women made. This lack of autonomy, according to its compounding of danger, meant ancient women couldn't avoid the risks of repeated pregnancies even when they desperately wanted to. The woman whose body was weakened by too many closely spaced pregnancies couldn't choose to stop. The teenager whose pelvis wasn't ready for childbirth couldn't choose to wait. The woman terrified by previous traumatic births couldn't choose to avoid pregnancy. The married woman, according to social and legal realities in most ancient cultures, had to submit to her husband's sexual demands and accept whatever pregnancies resulted. Modern reproductive health care, according to its transformation of women's lives, offers not just safety but choice. Modern women, according to their options, can choose whether and when to have children, can space pregnancies to allow their bodies to recover, can access contraception that actually works reliably, can terminate unwanted pregnancies safely, where abortion is legal. This autonomy, according to its historical novelty, represents a transformation as significant as the improvement in safety. Ancient women endured reproductive experiences that happened to them. Modern women, according to current capabilities, can make reproductive decisions for themselves. Yet, according to ongoing political battles over reproductive rights, even these modern choices remain contested and threatened. Understanding ancient women's experiences according to the lessons of history should inform modern debates. When we understand what reproduction looked like without modern medicine, when we grasp the suffering caused by forcing women through unwanted pregnancies, when we recognize the life-saving importance of emergency obstetric care, this historical knowledge, according to its implications, should shape how we think about contemporary reproductive healthcare access and policy. As you drift off to sleep tonight, after spending this extraordinarily long night with me exploring women's reproductive experiences across thousands of years, I want you to think about the continuous thread connecting ancient women to modern women. The woman in 1500 BCE experiencing menstrual cramps and the person dealing with period pain today are separated by 3,500 years of history, but connected by the same biological reality. The difference is that modern medicine offers relief ancient women couldn't imagine, pain medications that actually work, hormonal treatments that can regulate or eliminate periods, surgical interventions that can address serious problems. For childbirth, the transformation is even more dramatic. A woman in medieval Europe faced childbirth with a 5 to 10% lifetime risk of maternal death. A woman in a modern developed country faces less than 0.1% lifetime risk, about 50 to 100 times safer. This improvement represents one of the greatest achievements in medical history, built on understanding of anatomy, germ theory, antiseptic technique, antibiotics, anesthesia, blood banking, surgical skill, and institutional care system. But according to modern global health data analysed by the World Health Organization, childbirth remains dangerous in many parts of the world. In some countries, maternal mortality rates are still close to medieval European levels. The ancient experience of pregnancy and childbirth as potentially fatal isn't just history, it is ongoing reality for millions of women today who lack access to modern obstetric care. Understanding ancient women's experiences helps us appreciate modern medicine while recognizing how much work remains to make childbirth safe for all women everywhere. Sweet dreams, and may you wake tomorrow with deep appreciation for the medical knowledge and technology that have transformed women's reproductive experiences from nearly unbearable to manageable. May you remember the billions of women who endured monthly periods and childbirth without the relief modern medicine provides. May their strength, resilience, and determination inspire you. May their suffering motivate support for ensuring all women worldwide gain access to comprehensive reproductive health care. Thank you for spending this long night with me, exploring experiences that shaped billions of women's lives across thousands of years, yet were often invisible in historical records dominated by male perspectives. Thank you for meeting Nefertari and Althea, Tertia and Agnes, Valeria and Faustina, and all the others whose stories represent countless real women whose names we'll never know but whose experiences deserve remembering. Sleep well, and remember, every time you access pain relief for menstrual cramps, every time modern medicine protects you or someone you love during childbirth, you are experiencing a gift built on centuries of medical progress. The ancient women who suffered without these benefits made their way through impossibly difficult lives with courage we can barely imagine. Honoring their memory means appreciating what we have, advocating for those who still lack adequate care, and never taking for granted the medical knowledge that has transformed women's health from a story of inevitable suffering to a story of prevention, treatment, and survival. Good night, and may you wake with renewed gratitude for modern medicine, deep respect for the resilience of ancient women, and commitment to ensuring all women everywhere can access the reproductive health care that makes the ancient experience of unavoidable suffering a thing of the past rather than ongoing reality. Sweet dreams.